I'm already going to do clapping for you. So this is a major milestone in your career, your clinical and academic career, and I congratulate you. I also want to say, for those of you who are in the clinic still and working during this crazy time, you are doing the work of angels, and I think we all give you, can we all give thumbs up to the clinicians who are working tirelessly during this crazy time. I also want to congratulate not just the also the mentors who have done tireless work for people, for the students in terms of getting them ready for the day and training them. And also I want to thank you to the readers as well, in terms of giving feedback. And this is the next step in your amazing careers, and I look forward to see what you're going to do. I do wish we were all together in the same room. When we said we were going to be online, who knew it was going to be really online? We thought we would see you this weekend, today actually. And if I did, I'd give you a real hug, but I'm giving you a virtual, that's my hug, virtual hug. So, oh, and there's Mari and Pam. Oh my God, we have more people. Lynn. Oh my God. So Lennon, Dr. Graho said, Glenn, keep it brief. So I'm gonna keep it brief. So I'm just very proud, and I'm gonna mute myself now because I can't stop talking.
Thank you, Dr. Gillen. All right, we're gonna get started. Again, good morning, everyone. I am Dr. Lennon Graho. I am the director of the Post-Professional OTD program, and welcome to our second doctoral capstone presentations. Our Post-Professional OTD program has grown tremendously since we first started admitting our students in the spring of 2017. We started then with our first cohort of 2 students, and including the 4 who are presenting today, we now have 16 students in the program. The students we have already admitted for this coming academic year and will be starting in the fall will be one of our most diverse and seasoned cohort of clinicians, including our very first international student who will be based and practicing internationally throughout the doctoral program, and we're happy to have her here today. Last fall, we also started offering this program as a fully online program, making it available to students in different regions of the US and the world. We are incredibly proud of our curriculum design, and as you will see in today's presentations, the curriculum design is strategic in approach in that the coursework and outcome measures of learning for each course build on each other and support the capstone project of each doctoral student. We also take pride in our collaborative mentoring approach, that while each student has a content expert that serves as primary mentor from the beginning of the program, every course faculty is very much as heavily involved in supporting the student's capstone completion. And we remain to be, as of this date, one of the most rigorous OTD programs with a unique emphasis in expanding the role of OT in understanding, assessing, and addressing cognition. With the 4 doctoral students who will be presenting today, you will clearly see a variety of perspectives and ways in which we expand our understanding and utility of cognition as a central construct. In these capstone projects, you will hear about an intervention using a functional cognition approach to improve post-secondary outcomes of young adults with intellectual disability, cognition as applied to understand changes in knowledge, beliefs, and actions, components that make up the clinical competence of OTs in a building capacity program to support clinicians working with LGBT older adults, cognition and other related performance skills needed for kindergarten readiness, through the development and validation of a screening tool for children in the autism spectrum, and cognition as manifested in intrinsic motivation, choice, and selection of meaningful play through a practice model and technology-delivered assessment in children with severe multiple disabilities. Needless to say, this will be an exciting morning of celebrations and intellectual nourishment. Today's presentations, however, are not research doctoral defenses, but truly a celebration of the work of our students, the work they have completed, and how they have transformed as agents of change in practice. Before we begin, I would like to lay out some procedures and some ground rules being in a fully virtual environment. First, please know that this session is being recorded and we will be eventually sharing this in a public forum for the sake of family, friends, and guests who are unable to join today and have requested to view the presentations. Next, except for the presenter and the Capstone Committee, please keep your microphones on mute at all times. Please take the time now to check this setting if you haven't already done so. Each presenter is given a total of 40 minutes, 20 minutes to present their doctoral journey and capstone projects using their digital portfolios. The next 20 minutes will be devoted for discussion and conversation. A bulk of this discussion time will be reserved for the Capstone Committee members, their doctoral mentor, and the capstone reader. We will open the floor for the audience to ask questions, but in a moderated format. If you would like to give feedback and ask a question, please type them in the chat box located at the bottom of your screen once we open the discussion time. I will then select 1 or 2 questions from the audience depending on the time remaining. Lastly, as appropriate, please feel free to use the reactions button at the bottom of your screen. You may use the thumbs up and clap hands reactions as we introduce the presenter and at the end of each presentation. Please refrain from posting any reactions during the presentation and the discussion. We will have a short 5-minute break in between presentations for a quick stretch and transition between presenters. We will begin now with our first doctoral candidate, Katherine O'neill. She will be introduced by her mentor, Dr. Sharon Gutman, and her capstone reader is Dr. Razan Hamed.
It gives me great pleasure to introduce Katherine O'neill. Kat graduated from her Occupational Therapy Master's Program in 2017. Since that time, she's been providing community-based services through the New Jersey Division of Developmental Disabilities, where she assists adults with developmental delays to function optimally in the community. In her OTD studies, Kat has focused on the clinical practice area of adults with intellectual disability secondary to Down syndrome. Her OTD residency site was a nonprofit organization called Gigi's Playhouse Hillsborough, which is a facility that provides community-based therapeutic and educational programs to individuals with Down syndrome and their families. Here, Kat developed a pilot independent living skills program for adult clients entitled Living Independently is for Everyone, or LIFE. Kat's capstone's components consisted of developing a set of occupational therapy practice guidelines addressing the post-secondary transitions of youth with moderate intellectual disability, conducting a scoping review on interventions designed to improve independent living outcomes for transition-aged youth with intellectual disability, and developing an intervention protocol to enhance shopping performance in young adults with intellectual disability secondary to Down syndrome. Kat is an extraordinarily talented therapist and young scholar. Together, we co-authored 2 papers that have been accepted for publication, and I am entirely certain that she is going forward into what will be an esteemed career. I'm greatly honored to introduce you to Kat O'Neill.
Thank you, Dr. Gutman, for the introduction. I'm going to share my screen now. Okay, so I decided to pursue my post-professional OTD at Columbia because I wanted to gain the tools necessary to become an agent of change and to address the gaps that exist in clinical practice for young adults with intellectual disability as they transition from high school to post-secondary adult life. And for those of you who may not be familiar with this population and the associated gaps in practice, Young adults with intellectual disability experience a dramatic drop in services once they graduate from high school, which in turn leads to poor outcomes associated with the transition areas of post-secondary education, employment, and independent living. So that said, my overarching goal when I entered the OTD program was to fill these gaps and improve post-secondary outcomes for this population. So if you look at the bottom right-hand corner of the screen, you will see this figure that looks kind of like a funnel, which I believe represents my progression through the OTD program pretty well. So I started out with this broad goal of identifying assessment and intervention methods to improve post-secondary outcomes for young adults with intellectual disability, which again are the areas of post-secondary education, employment, and independent living. I then decided to focus specifically on the transition area of independent living and identifying interventions for this area for this population. And then I decided to narrow the scope of my work even further to the development of a shopping intervention for young adults with intellectual disability secondary to Down syndrome. So I'm going to switch over to the reflection page of my digital portfolio so I can discuss this process in a little more detail. So as I said, I started with this broad overarching goal of improving post-secondary outcomes for young adults with intellectual disability. And the first step towards this goal actually began very early in the program during the professional development courses. So as I began reviewing the literature, I found out that even though all three of those post-secondary transition areas I mentioned are all within the scope of OT practice, less than 10% of transition age students with intellectual disability receive OT services. And one of the most frequently cited barriers to OT involvement is that therapists don't understand their role in the transition process for this population. So after learning this, my mentor, Dr. Gutman, and I decided that one of the best ways to help OTs better understand their role in the transition process for this population was to develop a set of practice guidelines outlining assessment and intervention methods specific to the transition areas of, again, post-secondary education, employment, and independent living. So later on during the writing for publication course, I refined the practice guidelines, and then Dr. Gutman and I submitted them for publication in Occupational Therapy and Mental Health, which is a peer-reviewed journal, and it was accepted and published online this past February. So then after I wrote those guidelines and they were published, I realized that it was equally as important to educate the clients, their caregivers, and other professionals about OT's role in the transition process. So to do this, I co-led an in-service for caregivers of individuals with Down syndrome at my clinical residency site. And the in-service was structured as an interdisciplinary panel, which consisted of an occupational therapist, which was me, a speech-language pathologist, and a board-certified behavior analyst. And during the in-service, we discussed the roles that each professional plays in the transition process and how each discipline has a different perspective and can all work together to improve these outcomes for these students. So you'll see in the top corner, there is this section here that says certification program, and it may seem kind of like an outlier here, but in order to work towards improving post-secondary outcomes for young adults with intellectual disability, it was important for me to make sure that I had the training necessary to be competent in all of the areas of transition. So the one area that I felt I really needed to advance my skills in was employment. So I completed a 4-part certification series for employment specialists in the state of New Jersey. And this not only introduced me to the best practices in supporting adults with intellectual disability to obtain and maintain employment, but it also gave me more information on how to support these individuals and their families as they navigate through the supported employment system that exists in the state, which I learned was very complicated. So like I mentioned earlier, as I progressed through the OTD program, I decided to delve deeper into the post-secondary transition area of independent living. So the next step towards addressing this goal was to identify all of the existing literature on independent living interventions designed for the population of young adults with intellectual disability. So during the advanced evidence-based practice course, I did this by conducting a scoping review of independent living interventions for this population, and then I wrote a mini critically appraised topic synthesizing the evidence on effectiveness of these interventions. And this process really highlighted for me that there's a gap in OT literature specific to independent living interventions for this population, as only one of the 12 studies that met review criteria came from OT. The rest came from either education or applied behavior analysis. So after learning about this specific gap, I decided to again narrow the scope of my doctoral work even further by developing a shopping intervention for young adults with intellectual disability secondary to Down syndrome. I decided to select Down syndrome as the etiology of intellectual disability because I became intrigued by the unique patterns of cognition exhibited by this population during my clinical residency at Gigi's Playhouse, Hillsborough. So in order to really explore their cognitive phenotype further, during the Neuroscience of Cognition course, I prepared a case study on a young man with intellectual disability secondary to Down syndrome. And preparing the case study really allowed me to explore the neural basis of metacognition in this population and to explore how metacognition deficits can influence functional IADL performance, such as shopping. So I use this information to really inform my shopping intervention protocol. And what I learned about the importance of metacognition really drew me to Toglia's dynamic interactional model, or the DIM. And for anyone who's not familiar with the DIM, it's an OT metacognitive strategy training approach that focuses on really promoting functional change in clients by providing them with opportunities to practice self-monitoring skills, strategy generation, and applying the strategies across a variety of meaningful activities and environments. So although it was initially developed for adults with traumatic brain injury, what I came to learn and understand about the cognitive profile of adults with intellectual disability secondary to Down syndrome really led me to believe that a shopping intervention guided by the DIM could be effective. So that said, during the cognitive assessment and intervention course, I developed a shopping intervention protocol guided by the DIM, and it included such elements like the focus on self-monitoring and strategy training. I also looked at the use of the natural context. So for example, the protocol specifies that intervention has to occur in real life shopping stores throughout the community, and also assessment instruments used should be ecologically valid and performance-based. Another element of the intervention that was important was the use of an alternating group individual format for intervention sessions. And I chose to do this type of intervention because the use of a group intervention really allows for socially oriented learning, which, as I learned while I was preparing the case study, tends to be more effective for this population, while having the individual sessions really allows a therapist to cater to the individual client needs. So you really get the best of both worlds with this type of format. So when it became time to select a research project for my capstone, I decided to focus on testing the effectiveness of this shopping intervention protocol. So during the case-based application course, Dr. Gutman and I completed the IRB process, and we received approval from both Columbia as well as my clinical residency site, which is where I conducted the study. I'm going to now switch over to the capstone page so I can discuss the study in further detail. Okay. So I'm going to skip over most of the background section since I already discussed a lot of these points. But one thing I did want to point out was that the research question was, can an 8-week metacognitive strategy training intervention provided in a community-based setting increase observable shopping skills in adults with intellectual disability secondary to Down syndrome. So for the research design, we used a single subject ABA design, and that included a 2-week baseline data collection period, which was directly followed by 8 weeks of intervention. And then 1 month after intervention end, there was a 2-week follow-up data collection period, which I will be referring to as 1-month probe. So the participants were recruited from a convenient sample of adults from my clinical residency site. And to be included in the study, the participants had to be between 18 to 65 years of age. They have to have a diagnosis of intellectual disability secondary to Down syndrome. They have to speak English and also receive parental permission to participate in the study. Participants were excluded if they had a severe behavioral disorder that would prevent cooperation with the study protocol. And then you'll see in this table here, these are the participant demographics. They ranged in age from 21 to 34, and the majority were female, white, had moderate level of intellectual disability, had a high school diploma or more. The majority were unemployed, while 2 were part-time employed, and they all lived at home with their families. So for the outcome measures, we actually used a recording sheet that Dr. Gutman and I developed, and that's right here. You can see this table. As you can see, the variables of interest were time, frequency, and level of assistance required by participants to demonstrate the 6 observable shopping skills that are listed in the left-hand column here. So when I observed them, so I was the data collector, I completed the recording sheet as I observed participants while they were composing a 3-item shopping list, which was based on a recipe that was provided to them, as well as the food stocks available at the facility. And then I would observe them as they shopped for the items on the list at a local grocery store. So time was measured in minutes using a stopwatch. Frequency was only calculated for the skill of using store aisle signage to locate needed items, and that was done by tallying the number of instances that participants demonstrated this skill uncued. And I also wanted to note that the possible scores for frequency range from 0 to 3, since there are only 3 items on the shopping list. And then level of assistance was measured using a 5-point ordinal scale that you can see in this table below, where 1 indicates full assistance and 5 indicates independent performance. So during the baseline data collection period, I observed participants 4 separate times as they shopped at 4 different stores throughout the community. And then I observed them again during the individual intervention sessions. So there were 4 of them that occurred during the 8-week intervention phase every other week. And then again, I observed them at the 1-month probe at doing 4 separate shopping activities at the same 4 stores that were used during the baseline and intervention sessions, just to have some consistency. So for the intervention, it was provided once a week for a total duration of 8 weeks, and the sessions alternated, like I said, between individual and group sessions. Each session was 90 minutes long and was split into 3 phases based on the DIM model. So the 3 phases were a pre-shopping phase, a shopping phase, and a post-shopping phase. So the pre-shopping phase was 15 minutes, and it occurred at the day facility. And this phase really focused on facilitation of strategy generation using questioning methods, as well as guided anticipation techniques, such that participants were asked to predict the total cost, item location, and time needed to locate items. Next, the shopping phase was 45 minutes, and that was held at a local grocery store. And halfway through the shopping activity, questioning methods were used to encourage self-monitoring. But other than this, participants didn't receive any cues or assistance unless they explicitly requested it or if there was a safety concern. However, participants did receive positive feedback if they spontaneously used appropriate strategies. So lastly, the post-shopping phase occurred at the day facility for the final 30 minutes of the session. And at this time, participants were asked to compare the predictions they made during the pre-shopping phase with actual performance. They were also encouraged to discuss any challenges they encountered while shopping, as well as the various strategies they used, and they also received guidance to identify how those strategies that they used could be applied to other contexts. Participants were then given the opportunity to prepare the recipe, enjoy it, and then they would perform cleanup and store the leftover groceries in the appropriate locations. So for data analysis, Dr. Gutman actually completed the data analysis process, which consisted of 2 separate methods. First, the data were graphed, and then we visually inspected them to determine whether there were changes with regard to level of assistance, time, and frequency. And then a Friedman's ANOVA with Wilcox and signed post hoc tests were used to discern statistical significance between the study phases. So because the results calculated for the group, so we did it for both group and individual participant performance, but they really mirrored each other, so I'm only going to review the group results just for the sake of time. So you can see the scores here in this table, as well as this chart here. So really what it revealed was that as a group, participants experienced statistically significant improvements in level of assistance, time, and frequency throughout all data collection phases. And the largest improvements were observed from baseline to 1-month probe. And this is important because it suggests that participants not only maintained the improvements 1 month after the intervention ended, but that they continued to make gains. So even though these results appear really promising, there are, of course, some limitations. So first, the findings cannot be generalized to the larger population of adults with intellectual disability because it was a small sample size and we used convenience sampling. So future studies should include larger sample sizes with more rigorous study designs to accommodate for this. Another limitation is that I performed both data collection and intervention. So I was not blinded, and this could have biased the results. So in the future, studies should use independent interventionists and data collectors who are blinded to both study purpose and participant performance to decrease the risk of bias. Also, another limitation is that since maintenance data was only collected 1 month after intervention end, there's no way to determine whether those results were lasting beyond that point. So future studies can better assess the extent to which the gains are maintained by including an additional follow-up probe at 6 months. Another limitation was that the psychometric properties of the outcome measure were not formally evaluated. So even though it appeared to be ecologically valid because it was based on observations of real-life performance, we didn't actually conduct a psychometric study. So future studies should incorporate ecologically valid outcome measures with established psychometric properties. And then lastly, we only looked at the intervention of metacognitive strategy training. We did not look at the traditional approaches or other types of interventions to improve shopping and performance, such as response prompting. So future studies, if they wanted to determine the effectiveness in comparison, should include a comparative effectiveness study. So I just wanted to conclude with some anecdotal information regarding the participants' experience. They all of them reported that they enjoyed the intervention, as well as their caregivers, and they said that they benefited from it. So they all also expressed a desire to continue participating in the intervention after the study was over. So I actually wrote a grant proposal during the grantsmanship course to fund this program for another 12 months so that we can continue offering it, and it would occur 5 separate times because it's an 8-week program. So in conclusion, this seems to be like a promising intervention, but future studies really need to evaluate whether or not this is effective for the larger population of adults with intellectual disability by using more rigorous study designs and a larger sample size. And I just wanted to show this photo here. These were actually not taken during the research study. They were retrieved from the the website of the clinical residency site. However, we were shopping for a bake sale that we were completing. So these are the types of participants that would benefit from this study. They were both group and individual. And that is my study. I'm going to stop the screen share.
Thank you, Kat. Before we start with our 20-minute discussion, I just quickly want to acknowledge the presence of AOTA President, Dr. Wendy Hildenbrand. Dr. Hildenbrand, thank you for joining us today, and all of our other faculty, guests, alumni and students in the program who are here. Thank you all for joining. Dr. Gutman and Dr. Razan Hamed will start the discussion. If the audience has questions, please feel free to type them in the chat function right now, and we will moderate that question after the committee has completed their conversation and discussion. Dr. Gutman and Dr. Hamed.
Okay, I can start. Kat, that was really an excellent presentation, and as I said before, you just were a joy to work with. After you have now completed your capstone project and you got the results you did based on the training protocol, how would you apply that to other daily life activities for this population?
So because this was inspired by the DIM, it really focuses on self-monitoring, so it can be applied by using those same strategies. So I explicitly, during each session, we would talk about different ways those strategies used during the shopping activity could be applied elsewhere. So, for example, one of the strategies that we used was visualization. So this was something that we would do before we would go into the store, visualizing where things might be located, especially because the participants had been to that store already. So something like that can be used. For example, let's say they are going to use public transportation. So visualizing how they would get to the bus stop, how they would pay for the bus fare, and so forth. So we explicitly would go over different ways to apply those strategies. So I think that's a really good way to segue into the use of this intervention protocol for other types of activities.
Thank you.
Great job, Kat. That was a really great study. And I have two questions for you. The first one, can you describe how if you had any interactions with the families and patients, the parents, how did they respond or react to the benefits and the gains they saw in their family members after applying this intervention?
So I actually have like a specific example that came right to mind. One of the participants who was on the older side, his mom actually told me she was surprised because she thought he had plateaued and she didn't think it was possible for him to learn these skills further. She thought he had lost them after graduating. And then I explained to her that, you know, never too late to learn. And she was so surprised that even after the intervention, he was continuing to do these, to demonstrate these skills outside at home. This is also an example of the skill being applied to a different context. He is an intern at the residency site, so he would participate in fundraisers, and he started handling the money because of the skills that he gained during the intervention. So he had his money sense and ability to calculate change had improved, that he was able to do that, which was a very different skill. So the parents were also just grateful because, as I said, a lot of these individuals, they don't have the services anymore that they once had. So they really expressed that they had continued to demonstrate these skills and that they benefited from the study.
Yeah, I agree. I love that because I feel like populations of intellectual disabilities, unfortunately, is one of the few populations that we kind of let go of after a while, especially when they turn into these, take these adulthood roles, you kind of let them go because, you know, you, as you say, people think they plateau or this is it for them. So this is great. And I feel this is a great contribution to the population. My second question, I'm sorry I'm taking so much time, is about your future direction with this. You did mention that future studies are needed with more rigorous research designs with larger samples. But if you were to pick this up tomorrow and continue research-wise, not only clinical, what would be the first step for you using the material that you used, whether it's the scoring sheet that you shared or the assessment tool, the homemade assessment tools that you use or the measures? How would you take this further to make this a more mainstream assessment tools or things that other therapists can use, community-based or in schools or in research? What would be your next step going forward?
So I actually thought a lot about this. So there are two different ways I could go and that I've been kind of thinking about. One of them would be, I would like to do a larger study, and because a lot of the participants at my clinical residency site were exposed to it, and now they kind of like, there's this word of mouth going around. So I think that I could get more participants, because that was really the largest barrier, was that a lot of people didn't want to participate because they just didn't have the time or see the value. So I would like to do a study with a larger sample size and a more rigorous design. So I would like to do a pre-post study and have the two groups, one of them being on a wait list. Because like I said, if we do receive the grant funding, which I haven't heard back yet, it would be for a 12-month period. So there would be 5 different cycles of it. So I would be able to use that as the control groups and the waitlist group and the experimental group. Sorry. I also wanted to look at using either a different assessment tool, like the test of grocery shopping skills. When I looked at this assessment tool, and Dr. Gutman and I developed the recording sheet, this was one of the tools that we looked at for guidance, just in terms of the skills that are demonstrated. So either using that as an assessment tool or establishing the psychometric properties of the assessment tool that we did make.
Great answers, thank you.
Thank you. Any other questions, Dr. Gutman and Dr. Hamad?
My only other question would be, Kat, you had mentioned that one impetus for your work was that you realized there was very little in the literature, in the OT literature for this population, both in terms of clinical effectiveness studies and just any type of anything in the literature. There was very little. Why do you think that is, and what would you do in terms of trying to help other therapists understand that this is a population that really could benefit from occupational therapy services?
So in terms of for occupational therapists, I think that Dr. Ahmed said it perfectly, that a lot of times people just forget about this population because since they have higher support needs, it just kind of becomes, okay, well, who's going to do it for them? So I think that using this study and training people to use this type of model of encouraging them to self-monitor and say less to get them to think more would help therapists feel more comfortable so that we can increase the services. I think that one of the main reasons, it seems, at least anecdotally from how I talk to other therapists, it's just a lack of comfort and knowledge of how to work with these individuals. So I think just exposing them to this alternate method would be helpful. And then in terms of other professionals, honestly, anytime that I work with or discuss this with another profession, such as education or applied behavior analysis, they really do see the value of OT. It's just that we're not visible because a lot of OTs aren't working with this population. But as soon as we start getting involved, they really do see the value because we have the additional training in not only just looking at the individual, but also the task and the environment, which is something that I think a lot of other professions don't really have the training to look at. So we do really have that extra value. And I've just found that just interacting with other professionals, they accept OT's role a lot more.
Thank you, Kat.
Great, thank you. Dr. Hamed, any other questions? I have a quick question for you, Kat, and then I'll choose a few questions from the chat. From a cognitive perspective, cognitive intervention perspective, I'm very curious about the process by which you generated strategies. And I know, commonly in many theories of cognition, one of the prerequisites is a certain level of metacognition or awareness of their performance. So talk to me a little bit about the challenges and the ease that you've experienced generating strategies for this population. And I'm curious what kinds of strategies they generated to overcome the task challenges.
Yeah, so I'm actually thinking of one participant in particular. I was actually very surprised. I think it also, like, as you become, if you allow them to use the strategies, it's easier to see that they do have strategies. Everybody has strategies. Mm-hmm. So for example, one of the participants, when composing the shopping list, she pulled out her phone. She actually had an Android, which I learned is very user-friendly. Mm-hmm. And she used this list app to check everything off, and she used that as a strategy to group it and to keep track of everything. So I didn't say anything, I just let her do it, and then I just identified it for her, and using the language of saying, oh, that's a great strategy, kind of brought it more to their awareness that this is something that they're using. However, there of course were times that they were not able to generate an appropriate strategy. So I would use, I kind of talk about this in the paper, but it's, for the sake of time, I'll just like give one example. But I used it's kind of like the least to most prompting in terms of questioning, and this was taken from the DIM. But I would first ask like something general. So for example, if we're making the shopping list, I would say like, well, what strategies can you use to make the shopping list? Just something like so general. And then let's say that it was something like they needed to find cheese or something. I would say something like, oh, well, how do you know what you need? Well, where would you look to find that? Mm-hmm. Where would you find the cheese? And then like identify it, and then like narrow it down even further. Should you check in the pantry or the refrigerator? So stuff like that, and where it would get really general and then kind of like lead them to it. But in the end, they have to be the one to really identify it. So that was something that I used a lot. Also, really, the use of the group really helped with this because they learn from each other's strategies, just like how all of us do. So I would just point out the use of strategies like, oh, well, look what so-and-so is doing. That's a great strategy. And then they would all apply it. So I also, like I said, at the end of the sessions, we would explicitly talk about how the strategies that they used could be used elsewhere in other situations, in other contexts. So I found that it was actually a lot easier than I thought it would be. There was one participant that did have a significant expressive language disorder. So however, her receptive language was fine. So that was very helpful in that. It was just more of a challenge in like her communication, but we ended up using assistive tech for that, which is not my expertise. But
I'm glad you said that, though, that a lot of therapists really assume that converting from direct teaching to strategy facilitation is very difficult, but it's simply converting telling the patient what to do to posing probing questions that would make the wheels turning and make the clients, regardless of ability, actually be able to think and create strategies or create mechanisms to overcome a particular challenge, particularly with tasks. And I love how you mentioned that. There's a lot of feedback and questions for you, Kat, on the chat box. I'll highlight a few of them. One question is from Dr. Abruzzese, asking, given the range of intellectual disability that may exist, how do you decide if an individual has the minimum requisite skills to participate in and benefit from this type of intervention?
So I think that what I was kind of just touching upon, like the receptive language piece, is a big prerequisite. If they don't have the required receptive language to really understand the language that I'm using in terms of strategies, that would be pretty difficult. So you saw that it was moderate and mild intellectual disability. There were some clients that were kind of more borderline severe. The one that had the expressive language disorder, she did benefit from it, but not to the extent that the others did. And again, any improvement is good. So she improved. She didn't get to independent performance and everything, but that lessens the burden on caregivers when completing shopping tasks, because they don't have to do as much. So I think that's also a different way to look at it, is not necessarily looking at independence as a dichotomy, like independent or not, but like just improving their ability to participate in it. So I think that to an extent, pretty much every disability level of intellectual disability can benefit from this to some extent, but mild and moderate intellectual disability it seems that they benefited more.
Thank you. Dr. Gillen, you have a quick question on generalization?
Yeah, so am I on? Yes. First of all, wow, great. I'm so proud of you, actually. I remember you back in the day, and I was always proud of you then, and I'm more proud of you this morning, actually. The gentleman that you mentioned earlier, in terms of he became, what did you say? He became responsible for the money or the budget? Is that what was it for?
So we do a lot of fundraisers, and one of that is a coffee cart at a local high school. So first he would just pour the coffee, but then he was able to, and he expressed desire to, and had the skills to do it. He would handle the money. So people would give him the cash, and then he'd give them the change.
Right. So one of Joan Toglia's main focus is generalization, right? From one task to the next, or one context to the next. So you really saw that happening, it sounds like, from this intervention. So the model seems to be really working, right? In terms of theoretical model applied to real life. Do you agree with that?
Yeah, and another example, actually, that I just thought of, again, this is anecdotal, I didn't actually study this, but
sure.
One of the, so that gentleman, along with one of the participants, they're both interns there, and they were baking something at the Playhouse for a bake sale. I think they were making cookies. And I wasn't there for this, but the Playhouse director was, and apparently they did something where they like mixed something wrong, and she overheard them talking amongst themselves, and they were looking at each other saying, "What would Katherine tell us to do?" And they talked themselves through it, and like I was like, oh, I feel so bad for them that they have my voice in their head all the time now. But it's funny because it really did. We never baked anything. Everything was a simple cold meal, or to maybe using a microwave. But it had to do with something with measurement. So they were able to use kind of like the strategies that way. And then also another participant, the mom told me that now her husband uses some of the strategies. So like the participant was teaching his family members how to use the strategy, so they talk about it at home. But it's really, it was very
I think you really demonstrated that the theoretical model is applied to everyday life, and that's an amazing thing. So thank you and congratulations. Great presentation.
Actually, Kat, that feedback, that what would Katherine tell us to do, is actually strategy generation in and of itself. So I think that's really great. Just very quickly now, because we're almost out of time, there's a clarificatory question from Dr. Falk-Kessler. Can you just briefly describe a little bit more in detail what was some of the details or essential elements of the intervention?
Okay, so the intervention, so I focus on self-monitoring and strategy generation. So I did that by separating the the session into 3 phases, like I had mentioned, so that we can focus on the guided anticipation, which was the predicting their performance, which they were then able to compare with their actual performance. Also, another one of those things was when during the shopping activity, I'd interrupt them halfway through and kind of just question them to say, like, how are we doing? What is working? What's not working? To encourage them to monitor their performance during the task. And then also, like I was saying, the facilitation of strategy generation, so the questioning methods. So that was really the main element. There's also the use of the alternating group individual format, which I think was really important here because, like I said, it was a socially oriented learning and they also learned a lot more from each other. But then using the individual sessions, I was able to tailor it more to their needs because, like I said, one of them had an expressive language disorder and none of the other ones did. So it was something that I could really tailor it to her needs. And then some of the other elements were the transfer continuum. So we used different recipes every time. So every time they shopped for different items at 4 different stores. So we did use the same 4 stores at baseline, intervention, and 1-month probe just for consistency in terms of being able to compare it. But they were 4 different stores. So being able to use the strategies in a variety of different environments and looking for different items. And then there was also the explicit identification of how these strategies used could be applied in other contexts. So that was really important to it as well, because without explicitly identifying it, it was something that they honestly they expressed to me they didn't think about. So one of the other essential elements that I didn't really cover here, and I didn't really explicitly measure just for just feasibility reasons in terms of being able to interact with the parents. But in the intervention protocol, there is an explicit call for caregiver education to promote carryover and like how to use these types of questioning techniques in other situations and at home. Unfortunately, I wasn't always able to do this in the study, so I didn't include that as an essential element here because a lot of times the parents they were working or they couldn't, we didn't have contact after. They would just drop off and pick up. So that's not something that I identified in the study.
Thank you, Kat. Congratulations. And thank you to Dr. Gutman and Dr. Hamed for all of your work.
Thank you so much.
On the committee. A big warm round of applause for Kat, please. And Kat, when you get the chance, there's a lot of messages for you and congratulations on the chat box.
I keep seeing the little orange thing.
Absolutely. We'll take a quick 5-minute stretch break as we transition to our second doctoral candidate.
Hi, Wendy. How are you?
So I was going to say, can I talk for like 2 minutes?
Of course you can. Really? Of course you can.
Oh, cool. You know, I had this totally on my list all week. I think you stumble on things in Facebook. And so I was like, this is exciting. And then I woke up this morning going, oh, shoot, today's the day. I better get to it. So anyway, what fun. This is great. But,
thank you for joining us. Is everybody healthy in your life and safe and everything like that?
You know, we're healthy. Life is good. I mean, we're staying at home. Our order goes through the 15th of May.
Mm-hmm.
You know, we obviously don't have near the level of just events happening there. Just can't even imagine. But you know, it's just, everybody's got their own storm, and.
Yeah.
And we're weathering through, but yeah, healthy is good. We've had, there's always people connected in one way or another that have something going on, and it's certainly being impacted health-wise and economically. So it is a tough thing, but you guys are definitely, kind of leading the way there in New York with, hey, if we can do it, you can do it.
If we can make it here, we can make it anywhere.
I heard a song. I mean, there's a song that goes like that. I was hoping you'd pick up on that, of course, indeed.
Well, thank you for joining us. We're honored to have you, I think.
Oh, no, I was just glad it was public information. And so I really appreciate that, that I was able to pop in there. And it was cool to be able to hear her talk about that from a grocery shopping standpoint, because you know, the work that Tana did, obviously she did that at University of Kansas, and I was a part of her initial group, you know, when we worked on that. So I was like, how cool is that? So so anyway, so really appreciated being able to join you all. Thanks for having the open forum available for people.
Thank you.
Thank you.
Thank you for coming.
All
Stay
right,
safe and healthy.
I'm going to jump out, but I also want to make sure I said a wave to Razan and Pat. We go way back now, all the way back to Morocco. So.
Oh, Morocco, right.
Love you guys. So, hey, have a good day. Talk to you
Thank
later.
you.
Thanks, Wendy.
Okay,
Thank
bye-bye.
you.
Phyllis, I'll ask you to stop screen sharing first
Okay.
until after I introduce you. Thank you. Lots of people on the chat box and on present here today.
Yeah, we have a nice crowd, actually, if you scroll through.
Family, friends, guests, colleagues, classmates in the program, alumni. Hello to you all.
Hey guys, I have to log off, but I wanted to say hello. I miss you all.
Oh, hi, Clarice. Thank you.
Clarice, you have your PPE. I'm so happy that you have that.
Me too.
Yeah. Well, you're in acute care? Yeah. Well, thank you for doing what you're doing.
Everything. Right. Thank you for everything.
And that's crazy because I'm seeing Clarice and she's probably 5 minutes from where I am right now.
Oh,
Probably.
Here
I'm at
in
North Kansas City.
You betcha. That's right. I know. I love that you're there representing us well.
Thank you.
Thank you.
Do you have a good mask though? That's not a great mask you have on. Do you have an N95 or no?
We only get to use them with COVIDs who are aerosolizing. So I'm on ortho and cardiac today.
Okay.
So I've got a couple, but I don't need to use them today.
Okay. Well, thank you for all you're doing. It's really, I'm not a religious man, but it's the work of God. No, it's really, I can't believe what the clinicians are going through right now. It's just,
It's been a lot of change. I'll be
it's
glad when I
stunning
get
though.
back to
It's
normal.
stunning. Well, it's going to be different for the rest of our lives, I think.
Yeah.
You know, in terms of how we handle patients. And so thank you so much.
We have
Thank you,
54 people on the call. Isn't that amazing?
How many?
54 people.
Oh, wow.
Like a full class.
Glad that I kept it not seeing the people I would have.
Yeah. All right, everyone, we're going to transition now to our second doctoral candidate. So I'll ask everyone again.
Catherine, you were wonderful. I just figured out how to unmute.
Thank you.
Now we'll ask everyone to figure out how to mute themselves.
I'll go back now. Congrats, Catherine. Congrats.
Thank you.
All right, everyone, we're going to transition now to our second doctoral candidate, who is Phyllis Simon. I will be introducing her as her mentor, and her capstone reader is Dr. Pat Priesen. Phyllis Simon graduated from Columbia's OT program in 1988 and began her career at New York Presbyterian Weill Cornell Medical Center, where she worked in acute care and outpatient settings with specialization in neurological and cognitive rehabilitation. In 1997, she began her academic career at Mercy College with teaching responsibilities for adult and geriatric coursework. She joined the faculty at Columbia's OT program in 2007, teaching the older adult curriculum and coordinating the Level 1 fieldwork program. Phyllis has always maintained a clinical practice with older adults in subacute and long-term care, home care, outpatient, and other community settings. She has been actively involved in interprofessional teams and collaboration throughout her 30-plus year career, and was recently inducted as a fellow to the National Academies of Practice for her contributions to interprofessional practice. In 2015, she joined ELINC, which is the Elder Lgbt Interprofessional Collaborative Care Program, a grant-funded research project that combined clinical care for the LGBT older adult community and education of interprofessional healthcare students on aging, LGBT topics, and interprofessional practice. Her involvement and role in eLink laid the groundwork for the focus of her doctoral journey. Her doctoral capstone project focused on developing a building capacity program to enhance the knowledge, beliefs, and actions of OTs working with LGBT older adults. So my dear colleagues and friends, it is my pleasure to introduce Phyllis Simon.
Thank you. I'm just going to share screen. Thank you very much, and good morning to everybody, and thank you for spending the morning with us. As Dr. Graho noted, my doctoral journey really grew out of my role on the eLink team. This experience made me question the needs of LGBT elders, how and if they differ from their heterosexual peers, and consider what the role OT has and what particular considerations may need to be made to address and ensure best practice for this community. Just some background information. The growing population of older adults in the United States includes a concurrent rise in the number of older LGBT individuals. There will be over 7 million LGBT elders 65 and older by 2030. Issues and concerns of health disparities, lifelong discrimination, victimization, abuse, fear of the healthcare system are common themes that are well documented in the literature. Healthcare providers, including OTs, really across all practice settings need to be prepared to address not only issues related to aging, but the issues and concerns faced by this population. Currently, there are no standards across health professional education programs or in clinical practice to ensure that students and practitioners are LGBT clinically competent in order to address this community's needs. My experience in eLink prompted me to really explore my own clinical competency for working with LGBT older adults and made me realize what's needed to promote best practice from an OT perspective. I felt compelled to explore what kinds of changes, considerations needed to be made to facilitate practice, and really how could I add to the body of literature to help guide OT education and clinical practice. Presently, there's limited information, both from an OT and even from a rehab perspective for working with this population. My doctoral objective grew out of this experience with the end goal to facilitate OTs who are agents of change to support the needs of LGBT older adults. Keeping that in mind, my capstone projects and the whole process really focused on 3 elements: the development of a practice model to identify the needs of the community and the role OT can play in providing clinically competent care, the development of a self-assessment tool to assess the capacity of OTs to support the needs of the LGBT older adult. And also I'm going to be discussing the implementation of a community of practice for OTs to also facilitate clinical competency for working with this population. I'm just going to move forward to the reflection process. So as I said, the doctoral process goal was really looking at how to create these agents of change. As I went through my coursework and began to develop my capstone project, my clinical and research experiences, background in cognition, and role as an educator all came together. This process had 3 phases, and I'm going to speak about each of these phases. Phase one really started out in terms of setting and looking at the theoretical perspectives and constructs in occupational and social justice. Many concepts and theories presented through the OTD curriculum were evolving when I was in OT school 30 plus years ago, or were developed afterwards. I actually chose to use the Person, Environment, Occupational Performance Model, or the PEOP model by Baum, Christensen, and Bass to illustrate and describe the narrative of the LGBT older adult community. Identification and analysis of facilitators and barriers on occupational performance, participation, and quality of life was done from a systems and a population perspective. This framework facilitated my development of a proposed practice model for working with the LGBT older adult community. I also explored the impact social and occupational injustices have had on the LGBT older adults. The impact of choice and creative inclusive environments are essential for creating a better and quote unquote just experience in today's world. This principle emphasizes the struggle and the need for inclusivity for this community. Despite the hardships, the social injustices, and bias this community has endured, literature is now pointing to the positive aspects of marginalization in fostering coping strategies and resilience due to the years of adversity, discrimination, and stigmatization. In this case, marginalization and social injustice may actually be resulting in positive traits that are fostering more favorable outcomes. And I felt like this was critical foundation knowledge that I needed to highlight as I developed my practice model. When I moved into phase 2, there are actually 2 different sections of phase 2, and I'm going to proceed to go through each section in more detail. Cognition is a thread that is addressed throughout the OT curriculum. My experience and background in cognitive rehab was a match that allowed me to gain greater understanding of the issues regarding cognitive health of LGBT older adults. Concerns related to age-related cognitive changes, cognitive health and reserve, and functional cognition were explored through in-depth literature review and case study application to LGBT elders. Greater understanding of the risk factors, the health disparities, and increased rates of mental health disorders all impact the cognitive health of this group. These issues, as well as their medical histories, both past and current, and social environmental contexts, all impact cognitive functioning. Metacognition, lifestyles, habits, routines, and decision-making are all influenced by many of these factors and impact quality of life, as well as even end-of-life care decisions. And all of these were addressed in all of the cognition courses as I moved through the coursework. The other arm of phase 2 addressed LGBT competency in education. Are we prepared as OTs to meet the needs of this group given our education and training? Identification of the role of OT and our readiness and ability to provide clinically competent care became a primary question. And I started questioning myself, how are other professions addressing this issue? The topic of my critically appraised paper investigated programs and educational methods that were used to address and develop LGBT cultural and clinical competency for practitioners and healthcare providers. There were no programs in the literature specifically relating or targeting OTs, but I did find that OTs were part of interprofessional training programs on LGBT health topics and cultural and clinical competency. This finding, too, helped reinforce my goal in creating a program for promoting LGBT clinical competency. Keeping that in mind and going back to my eLink experiences, I prepared a grant proposal for an internal agency here at CUIMC that included the development of an online elective for interprofessional healthcare students with a focus on LGBT health and aging and interprofessional team collaboration, similar to what we used in the eLink program and also similar to other programs that are found in the literature. The grant proposal aim is to promote LGBT competence as well as provide an interprofessional experience for CUIMC students. This too demonstrated another mechanism or a means to achieve my doctoral goal of fostering the agents of change for improved healthcare for LGBT older adults. My work and in-depth literature review through the coursework also evolved into a manuscript titled The Role of OT in Supporting the Needs of Older Adults Who Identify as LGBT. It's been submitted to OJOT and is currently under review. The manuscript presents the LGBT older adult narrative story and what the role of OT really would encompass. Implications are discussed for clinical practice and education, and recommendations for promoting change to ensure best practice for this community is addressed. As I finished up phase 2, I'm now going to discuss phase 3. Phase 3, which is developing my Building Capacity Professional Development Program, or the Community of Practice for OT. It's here that all of this information all came together. My involvement in eLink was the initial stepping stone for this project. I served as a clinician, a researcher, and an educator on this interprofessional team. Greater understanding of the population was gained through in-depth review of the literature, working with an amazing interprofessional team of clinicians and providers from SAGE, an organization that services LGBT older adults, and my clinical encounters with the LGBT older adults themselves through this program and study. The eLink student elective focused on LGBT health and aging content, as well as interprofessional team concepts, was also vital to this experience. This too helped solidify not only the need for clinical competence, but helped me define the role OT can play with this population. Cultural humility and sensitivity and cultural competence and its impact on clinical competence in OT practice were concepts that were threaded throughout my capstone process. The question continued to arise: are we as OTs and as a profession prepared to address the multiple concerns, issues, and circumstances to provide clinically competent care to this population? The next question that really came up is, how might this be assessed from an OT perspective? And the next step was the development of the OT clinical competence, or the CCA LGBTE clinical competency assessment for OTs working with LGBT elders. I'm hoping it's a little bit tight in here, but this tool is a self-assessment of clinical competency for OTs working with, as I said, with this population. Aspects that contribute to clinical competence include knowledge, beliefs, and actions, which were the basis for the structure and the items included in the assessment. The CCA LGBTE was piloted during my project. I'm just going to scroll up a little bit so you can see how it's broken down. But the CCA LGBTE was piloted during my project, and there are plans in place to continue with psychometric property testing and to validate this tool in the future. Spearheaded by the need to promote clinical competence and facilitate agents of change, I chose to implement just going to go back here. I chose to implement a capacity building professional program using a community of practice approach. Wegner describes a community of practice as, quote, a group of people who share a common concern, set of problems or passion about a topic, and who deepen the knowledge and expertise in this area by interacting on an ongoing basis, end quote. The LGBTE community of practice combined my educational skill set with knowledge gained through my eLink experiences and my doctoral coursework. Just going to move ahead and then proceed to talk about my capstone project. So the study actually sought to evaluate the impact of participating in a community of practice for developing clinical competency for OTs working with older adults who identify as LGBTE. The cognitive orientation to daily occupational performance, or the COAP approach, was used in designing and implementing this program. Essential elements included using self-generated case stories, identification of issues and concerns, collaborative sharing of information, development of action steps and goals, all geared towards the aim of translating knowledge into practice and promoting clinical competency. This forum provided a venue for exploration, or really a safe zone for participants to also explore their own cultural humility, sensitivity, and cultural competence. IRB approval was obtained, and recruitment was actually done through Columbia's OT's Facebook page, AOTA's Productive Aging Special Interest section, and Commune OT through AOTA's website. A one-group pre-test, post-test mixed methods designed was used. The program actually consisted of 5 90-minute sessions over the course of 4 months. To ensure building capacity program adhered to Wegner's principles of community practice, we used a fidelity of intervention checklist that was generated by Graho and Sheffield for AOTA's Community of Practice Division. A student researcher participated in the sessions and completed the fidelity checklist for each session. All sessions were found to adhere to the fidelity of intervention. Each month, topics for discussion were generated and identified by the participants. Topics included the use of proper terminology, OT assessment and intervention strategies, environmental considerations, policies and regulations related to or that impacted the this population, available resources and strategies for dealing with site administration and management. A special guest expert, an OT with an expertise in the area of LGBT health, joined us for one of the sessions as well. During the sessions, many topics were addressed. We reviewed self-generated case stories and case studies. We discussed challenges we faced for competent patient care. Documentation concerns was a big issue that came up. And also it allowed a forum for analysis of inherent biases, perhaps that clinicians had, or even experiences with coworkers. The community of practice provided also an opportunity for a shared development of an in-service PowerPoint presentation that could be used to orient clinical staff about clinical competence working with LGBT older adults. I'm just going to proceed down and just, the CCA LGBTE was used as a pre and post outcome measure. A non-parametric Wilcoxon test was used to analyze the differences between pre-test and post-test median scores for each item. Qualitative feedback was collected after the final session to describe the experience of participating in the community of practice program, and qualitative responses were also coded and analyzed. So I'm just going to give you an overview of, I'm sorry, I'm bouncing around, of the results. There were actually 10 participants in the study. 7 were female, 2 were male, and 1 participant identified as transgender. Clinical practice experience ranged from 1 to 20 plus years experience, with an average in the bracket of 5 to 10 years. Luckily, the participants were also geographically diverse, with 4 coming from the Northeast, 2 from the South, 2 from the West Coast, 1 from the Midwest, 1 from the Mid-Atlantic region, and 1 participant even reported being from a rural area. So it was a nice range of looking at how things are across the country. Practice settings were also quite diverse. 2 participants worked in hospitals and acute care settings. 1 worked in an inpatient rehab unit. 2 participants were mental health OTs working in inpatient settings. 2 clinicians worked in home care. 1 participant worked in a PACE program, or a program for all-inclusive care for elderly. And there were 2 academicians, 1 from an OT program, master's program, and 1 from an OTA program. Now what I'd like to do is just go through the CCA LGBT, the self-assessment tool. Outcome data revealed statistically significant changes in 6 out of the 8 knowledge questions, 1 out of the 10 belief sections, and 2 out of the 10 action items. So the items that are that have the asterisks were the ones that were found to be statistically significant. The score changes indicate increased knowledge of health disparities, challenges faced by the clients, the available LGBT-friendly community resources and referral sources, laws, policies, and regulations, and consistent use of terminology and strategies to promote inclusivity. I'm just going to scroll down so that you can see the items in each of the sections. So in the belief section, you could see there was the 1 item, number 17, that spoke to sharing similar political and cultural beliefs. that promote inclusivity. And in the action items, there were actually 2 items, 23 and 25, about they gained referrals and also more attention when completing an occupational profile. Qualitative data revealed the most useful aspects of the community of practice experience were sharing resources, learning knowledge-based information such as terminology, health disparities, and the commonality of similar challenges. Some clinical action changes that were noted by the participants included more awareness, sensitivity to the needs and concerns of this population, including more consistent use of inclusive terms and language. But also, I felt this was a really strong one about advocating for environment and system changes with administration at clinical sites. Some of the limitations that were identified by the participants included the need for more structure during some of the sessions, and wishing that there was more of more focus on action items for the participants. And this may have been reflected in why we saw the greatest number of statistical changes in the knowledge section versus the other 2 sections. The community of practice really was a safe zone and a platform for participants to explore cultural humility, cultural sensitivity, and cultural competence, which are critical skills for OT practice. The commonality of struggles and challenges was overwhelming despite the range in the participants' clinical practice settings, their years of clinical experience, and the geographical location. Overall, the study demonstrated a positive impact of a capacity building professional development program for facilitating clinical competence for work with LGBT older adults. And my hope is also that this may carry over into just the LGBT community that clinicians work with as well. Some of the recommendations I have just based upon this study include further development of a community practice model as a means to educate and promote clinical competency of OTs to ensure that LGBT older adult needs are being met and that best practice is being provided. As I said earlier, the validation of the CCA LGBTE tool is in the works, and it's planned to move ahead with psychometric property testing, as there's nothing that's directly related to OT practice. There are many tools that exist that explore just general issues of care. And the last one, the last recommendation is also continued outreach and collaboration with AOTA's networks. And this really includes through AOTA's productive aging section, which I'm involved in, as well as the LGBTQ network, which really has grown considerably over the years. In conclusion, I really feel like I've made progress and I feel empowered to foster OTs as agents of change for LGBT older adults through my role as an educator, as a clinician, and a researcher. So thank you, and I want to appreciate everybody open to questions.
All right, Phyllis, can you end screen share, please? Thank you. And Dr. Pat Friesen and I will start the discussion with Phyllis, and then feel free to type your questions and feedback on the chat box, please. First, Phyllis, congratulations. I know that this has been a lot of work. It also included a lot of your passion for this practice and for this population. I wanted to ask first, your primary design is a community of practice approach, and you and I both, went through discussing this approach, really getting you used to this approach. Can you share with us and with the audience today describe briefly how you navigated the 90-minute sessions using a community of practice approach? What were the paradigm shifts that you'd have to undergo in using this format? And what were some of the challenges and strengths of this approach?
So I can remember being on the phone with Dr. Graho before my first session, and I just heard you in the back of my head, do not teach, do not teach. And really, I think my role as an educator to being a facilitator was probably the biggest challenge that I faced, because it really is a community, and being able to facilitate the crowd was the participants were a wealth of knowledge themselves. And that was probably the biggest challenge, I think, for myself. It's definitely a paradigm shift. Yes, I put it together and I was facilitating this, but in some ways you had to move away from being the teacher in light, and I had to work more towards prompting questions, but not everything was up to me. So that paradigm shift was probably most challenging for myself. And I feel like my role as a faculty and as an educator was a pro and a con somewhat with that. The stories that people shared, I was really struck by really the commonality of the challenges that people had, despite the varying clinical practice areas, and despite there was a range. Yes, I was probably on the other end, but there were people that also had 20 plus years of experience as well, with people that were newer clinicians. But the sharing of similar challenges and we talk about cultural humility and sensitivity, and everybody had the same feelings. You felt bad sometimes where you didn't want to offend somebody, or you asked the wrong question, or you didn't use the right terminology, and everybody had stories like that. And I think it was an open forum that everybody felt comfortable saying that. So that was a real positive thing. That I also, my work in the field, when I started working with Ilan, that was a challenge also. So that was a big thing. But the community of practice model was great. We had a shared Dropbox, people exchanged resources, and it was great learning from other people as well.
Yeah, and let's go back to that CCA LGBTE questionnaire, your cultural competency assessment. So it measures knowledge, beliefs, and actions based on the analysis that you did. A majority of the changes were from the knowledge domain. So very obvious, there were a lot of improvements or increases in the knowledge and awareness of the participants. Some there's one aspect in the beliefs, and some in a couple questions in the action section. Can you, and I know you already alluded to this in your presentation, but can you hypothesize for us some of the reasons why you think the changes in the clinical competence of the participants, a lot of the changes were more on their knowledge domain compared to the beliefs and actions? And perhaps you can tell us a little bit about the baseline demographic or capacity of your participants.
Yeah. I found that striking as well when I began to look at the results as well. The knowledge, I think, comes out about, I think people have a general understanding of some basics. They might know some terms, but understanding when you get into the literature of really looking at the health disparities, when you think about this population itself, you really have to put it in perspective of how do they differ perhaps from a younger generation. And we sort of discussed that, right? We discussed that this is the generation that went through information. So a lot of this knowledge sharing about programs, about resources, people aren't that familiar with all these types of programs. Also, there are very few sort of centered like LGBT programs. I mean, SAGE was a unique experience that does, but most of the clients and most of the patients that people deal with, not everybody, on a spinal, they might have one or two patients that came across their caseload. So it really depends upon where your practice area was. So I think the areas that we looked at, the policies, the regulations, and this is also information that is not generally gained in educational programs either. And it's not until you have a patient that you need to refer somewhere or you want to provide resources that's going to come up. The beliefs, when you look at the beliefs items, a lot of them are things I think that are also ingrained in sort of ethical practice. And I in looking at them, it's a comfort level. It goes into, the questions are, am I very comfortable working with LGBT older adults? Am I comfortable speaking about issues? Some of this is, these are areas I think that are just innate in clinical practice. And the action items really, again, are more related to documentation. They're more related to ADL issues. And unless you're there was one of the participants actually worked in a surgical program that worked with clients who were going through transition surgery. So, the action items were things I think that are ingrained in general practice also. And those were things that, unless you're doing it over and over again in clinical practice, it may not necessarily get addressed.
Mhm.
But I could see how when therapists had the patients on the caseload, it becomes more important and more relevant.
Thank you. Dr. Priesen.
Well, I'd like to start by saying thank you so much, because I think this is a huge contribution to the OTs and much needed and very timely. So wonderful job. My question is very similar to Dr. Graha's last question, and I'll ask it more specifically then. Were you able to collect demographics on the participants and how many identified as LGBTQ themselves?
One of the participants actually identified himself as transgender. None of the other participants actually identified as being part of the community aside from that person. So, but there definitely was open discussion about, and I felt the group really evolved in terms of how the comfort level with each other and the issues about how they felt. So that was actually a positive aspect as well.
So you were able to see changes in the way people thought about the population too?
I think people felt more comfortable that let me retract that for a second. I think the fact that they felt more comfortable when they addressed clients, they felt like more empowered, that they were using the proper terminology, that they didn't want to offend a client, that they didn't, start saying, well, who was the significant person in your life versus saying, are you married? Do you have a spouse? And that I think became a trend that the participants sort of had. There was a lot of thought-provoking issues that arose, and clinical situations of dealing with caregivers, next of kin, different environmental contexts. One of the participants had worked within the forensic system, which opened up a whole different avenue. So it was really interesting to see how people in different clinical practice arenas, the situations that they came about.
Mm-hmm. I have one more question. Thank you very much. Do you think, you may have already answered this and by saying that you would like to continue this and that the people want you to continue also, but did you feel that the 90 minutes 4 times or 5 times was enough the first go around?
The first go around, probably not. I think for just getting it undergoing, we were getting into a phase, and I think more tangible outcomes, like concrete things in terms of getting other participants to bring, people didn't bring formal case studies. It was more like a discussion that happened, but I think more formidable issues would have been coming up, like, okay, how do you, like, I know I've never, addressed this. I've never had to train somebody to bind, right? I've never had to deal with that. And I think those are the action items. Like, how do you find out? How do you learn the skill set unless you're in a clinical environment that you need to? And I think those types of things, or how to share that. And I do think that some of those things come up at AOTA meetings, the LGBT, there's very limited continuing there, more and more. It depends. if you search, but from an OT perspective, that LGBTQ network really is rising. I didn't even realize when it first started, it was really just for LGBT clinicians. It wasn't for addressing the community, and I think that has evolved also now. And the Diversity and Inclusion Task Force through AOTA are also including it.
Thank you. Lots of great questions here, Phyllis, on the chat. I'll start with one of your collaborators in eLink, which is, again, the Elder LGBT Interprofessional Collaborative Care Program, Dr. Abruzzese. She asked that given that the origins of your capstone began with an interprofessional collaborative care team model from eLink, and one of your goals is the development of an interprofessional elective course, how important is it that the CCA LGBTE, the self-assessment tool you developed, was first developed as an OT tool rather than a tool that could be used more widely by an interprofessional team?
You know, it's very interesting because we used a self-assessment tool for our elective as well, and a lot of it did come out of it. But when I actually wrote the grant proposal, I actually modified the CCA LGBT for an interprofessional audience. There are some very specific items, particularly in the action items, that deal more specifically, use OT terminology, and it was mostly because of that. But when I did write the grant proposal, I did actually modify this with the hope of using it and using this model for an interprofessional group. So that's a great question, Laurel. I haven't forgotten about my interprofessional team, but it was sort of the focus because this was for OTs, but when I wrote the grant proposal, this wasn't going to fit. So my hope also, just in terms of the psychometric properties, and development, is to modify it and go forward with something that can be used interprofessionally.
Mm-hmm. One more, actually a combination of questions from Dr. Raphael Greenfield and Dr. Falk Kessler. So this is a great program that can be integrated in practice and education. How can we use this or incorporate this community of practice or this cultural or clinical competency program for our master's students for professional education, so that when we develop entry-level practitioners, they join the workforce already with this clinical competence? And we have a lot of OT educators and administrators present here today, which who might gain some ideas on how they could integrate this or incorporate this in their curricula and professional programs. Any notes or comments on how we can efficiently and effectively roll this out?
I think we've become a lot more, as an educator, I think we've become a lot more attuned and a lot more cognizant of perhaps incorporating case-based case stories across the lifespan. I mean, these issues, these issues start very young in pediatrics all the way through. So I think if you start developing that, I know obviously in my older adult course, I do have some LGBT health content issues and knowledge and topics that are woven into many areas. This brings up another point of, we cover so much diversity in our curriculums, right? And we deal with people, and it's part of our practice that we deal with people of all races, of all religions, of all different kinds of backgrounds. How do you start sectioning out what's appropriate for what, we'd be providing that kind of information? It's part of the ethical responsibility of a clinician also to sort of explore sort of what information do you need to know to provide best practice to address those issues, whether it's a religious background, whether it's someone from a diverse racial or ethnic background. So that sort of also came up with me, like, why is this different? And again, it sort of goes to the point of this community, right? Sometimes I think is sort of that the inclusivity when you look at programs like SAGE. Yes, I always felt like this when I worked with clients. I didn't treat my clients any differently than I did any other older adult. However, the considerations that needed to be made, whether it was looking at what rehab facility perhaps I referred them to, what practice they did, were there LGBT competent providers on the other side, were they attentive to the needs, or was it going to create a situation of bias and discrimination and fear for this client. But from an education perspective, there are definitely ways I think that we can incorporate it into the education. But right now, there's no standards from an accreditation board. Also, when I did the mini-CAT paper for advanced evidence-based practice, the only thing that I found there is actually, I think it's the District of Columbia that has some continuing education regulation regarding LGBT health. Topics as part of continuing, but across the all disciplines, and I looked at psychology, medicine, dental, pharmacology, there were no standards for it. So that's sort of the struggle with it. So I think it's up to us as educators, and I think for practice and clinicians to gain proficiency and competence.
We are out of time, but thank you all for your questions. Phyllis, there are a few more questions you might want to address later on individually on the chat box. But congratulations for all, and thank you for your great work. And thank you, Dr. Priesen, for helping Phyllis provide feedback. Again, we will have a quick 5-minute break, and we will transition to Danielle Alonzi-Gold in 5 minutes.
Thank you.
Dr. Simon, Dr. O'Neill, 2 new doctors are ready.
Yay! Is there a doctor in the
Last night, my sister came into my room and said, if you mess up tomorrow, does that mean you can't be a doctor?
You didn't mess up by any means, Kat, by any means.
I was trying to write you, Phyllis, but I sent Jessica Farman very loving messages.
Can I read my acknowledgements? I forgot to do them.
Sure.
I'll read them really quickly.
Jeff and Sigrid are on this Zoom.
I know, and that's why. So I my E-Link peeps are here. So this was my acknowledgements. I said there were I forgot to do it before. The participants in the project were a wonderful group of people, the clients of SAGE who were the backbone and inspiration for the project, my unbelievable E-Link team, who many of you are here, who I had the opportunity and pleasure to work with and learn from. It was truly an ideal interprofessional team. Laurel, my PT counterpart and friend, who was so instrumental and supportive through this whole process. My husband and my son, who tolerated my late nights, crazy schedule, and were my rock. My friends and family, my CUOT family, who I can't thank enough for their unyielding support, mentorship, and brains, I said. Some of whom I had the great pleasure of working as having as instructors and mentors. I don't know if Pat's still there. Dr. Priesen for serving as my capstone reader. Janet, are you there?
I'm here.
I know. Janet, who encouraged me to start this process long before I did, and gave me the smart advice to use my E-Link experience as my capstone. Do you remember that, Janet? We were sitting in
I'm just
crazy if you don't. Pammy, who always kept me sane and made sure I was quote unquote okay throughout everything. And Lennon, who never ceased to amaze me in how you made things manageable and always seemed to provide a wonderful perspective and insight. And you were truly an amazing teacher. And the last people I'm keeping in mind are my parents.
Oh, yeah.
I know.
Well, that's who I sent, and that's who Jessica got my secret message from Birdie. So tell her to read it to you.
My father, even in his last days, would say, "Are you doing this soon? Are you going to do this soon?"
Well, you did it, Dr. Simon.
Fantastic.
And they would be so proud of you, right?
They are.
Lennon, and Glenn, and the whole OT faculty, I just want to say how absolutely impressed I am with the whole design of your OTD curriculum and program, and how the participants are really able to use each course to develop the skills and develop the pieces that build into their capstone. It's a phenomenal design. I know from Phyllis how much they learned and gained from your mentorship every step of the way. Kat, your presentation also showed that in full form. It was phenomenal. You all, just as an entire faculty and team, do a really great job of supporting each other, supporting your students, and providing a really great educational model that should be like out there for all other programs to see as an exemplar. Like, it really is a really great, I know I'm saying great too many times, but I really feel strongly how impressed I am and wanted to share my accolades. And I'm off the call in like 2 minutes, but great job, Len and
Thank you, Laurel.
Thank you, Laurel.
Thank you.
Lennon's starting to cry, I see.
I know, you're gonna ruin my makeup.
You know, he's doing such a wonderful job moderating. It's as good as bingo was.
I'm assuming you have this on pause, the recording.
No, it's still recording. All right, guys, we're going to transition now quickly to our next presenter. Let me just organize my script here. All right, everyone. Our next doctoral candidate is Danielle Alonzi Gold. I will introduce her as her mentor, and her capstone reader is Dr. Amanda Serafian. Danielle graduated from the Columbia OT Master's Program in 2017 and started working at Kennedy Children's Center as a pediatric occupational therapist. She works with preschool children with autism and other developmental delays. Her work at Kennedy Children's Center and the children on her caseload led her to identify the gap in research on school readiness of children in the autism spectrum, particularly on how we communicate the results of assessment findings, primarily through the use of functional observations, to describe the readiness of these students for more structured schooling. This gap led her to develop the Kindergarten Readiness Inventory. Her capstone has focused on the development of this screening tool and identifying its preliminary validity and clinical usefulness. It is my pleasure, and it's been a terrific experience working with her, and to present to you now, Danielle Alonzi Gold. Take it away.
Okay. Hi, everyone. My name is Danielle Alonzi Gold. I've been an occupational therapist at Kennedy Children's Center, or KCC, for 2 years now. KCC is a 4410 preschool for children with autism and other developmental delays in Harlem. Most of the children on my caseload are diagnosed with autism, and they were the ones that really inspired my capstone project. My capstone project focuses on the development of the Kindergarten Readiness Inventory, or the K-Ready, as I'll be referring to it for the rest of this presentation. There are a multitude of assessments that are available to evaluate sensory processing, fine motor skills, visual motor skills, behavior, and academic skills for the neurotypical population, but there is a gap in available assessments for evaluating school readiness in children with autism. There's also a minimal amount of current research on how children with autism transition to formal education and their school readiness skills. So developing an inventory for preschoolers with autism may assist in bridging that gap between the available standardized assessments and the descriptive assessments to evaluate school readiness. So my capstone project was broken into 3 phases. The first phase was to identify gaps in research. The second phase was to understand the occupational profile of children with autism as they transition to kindergarten. And the third phase was the development of the K-Ready. So this figure is a chronological narrative of my doctoral journey and how each of the courses contributed towards my capstone project. So the first artifact is the program development artifact. And I was able to complete this artifact from the Advanced Application to Theory and Practice course and the Neuroscience and Cognition course. And it was through the Neuroscience of Cognition course that I was able to complete a case study on a child from my caseload in order to understand and build an occupational profile of that child as he's preparing for kindergarten. And in the theory course, I wrote a theory-guided practice model based on occupational adaptation, or OA, and dynamic interactional model, or DIM. So simply put, OA takes a holistic approach to understanding the ways in which the individual and the environment transact with each other. And DIM uses cues and adaptations to assist the child's probability for change. So the person, the activity, and the environment are all dynamic processes that influence each other. And OA-guided interventions for school readiness are adaptable to best meet the needs and the current level of the child. And DIM is compatible with OA in that the person, the activity, and the environment all influence each other. And similar to the OA model, facilitating the child's self-awareness and strategies through modifying external environmental factors are the hallmarks of DIM, and are also important aspects in assessing school readiness. So my education, continuing education, and professional development artifacts were produced by conducting an in-service at KCC for the OT and the PT department about the development of the K-Ready and the preliminary content validity and clinical utility of the tool. And I was supposed to do a poster presentation in Boston at AOPA conference, but unfortunately that was canceled, but there's always next year. So for the evidence-based practice artifacts, I was able to use my final work from the measurement course and the advanced evidence-based practice course. And it was in the measurement course that I completed the beta version of the K-Ready. And in the advanced evidence-based practice course, I completed a scoping review that I had started my first semester of the program to find gaps in research, which completed phase 1 of my Capstone project. And over the summer of 2019, Dr. Graho and I submitted an IRB to Columbia to conduct my research study to determine the content validity and clinical utility, which I'll go over a little bit later. So for my evidence-based research paper artifact, I, along with Dr. Graho, wrote a manuscript and submitted it to the Journal of Occupational Therapy, Schools, and Early Intervention, detailing the preliminary psychometric properties of the K-Ready. The manuscript is currently under review, and the contents of this manuscript is my Capstone project, which I'll describe in the next few sections. So I want to quickly talk about a personal anecdote. At work, we do Turning 5 reports, which is for all of the children that are going to kindergarten. And these reports go to the families, the schools, the districts, in order to place the child in the appropriate setting for kindergarten. So the first year I did the Turning 5 report, I just kept thinking about how there wasn't an appropriate assessment for our children in order to assess their basic kindergarten readiness skills. This was really one of the driving forces in creating the K-Ready as a multimodal, uniform, iterative approach to create a school readiness occupational profile. And so developing an inventory for preschoolers with autism may assist in bridging the gap between the available standardized assessments and the descriptive assessments to evaluate school readiness. So the K-Ready is a proposed assessment tool to assess the school readiness skills, specifically for nonverbal to minimally verbal children in the autism spectrum. So this chart was created during the measurement course, and the latent variable, which is that middle bubble, is what I'm trying to measure. The observable variables are on the outside bubbles. So the K-Ready will assess school activities of daily living, which includes toileting, feeding, and donning, doffing of jacket and shoes. Basic school concepts, which includes letter matching, number matching, color matching, and shape matching. Basic fine motor and visual motor skills, which is cutting, coloring, and copying figures. Social participation, such as following directions, turn taking, and play skills. And school behaviors, such as sitting attention, transitioning, and frustration tolerance. So subscales and items of the K-Ready were developed after I completed the scoping review of the literature on assessments that are currently used by OTs in practice. So each item is scored according to a scale of 1 to 5 with specific criteria descriptions for each item. So the assessor identifies the representing criterion that illustrates the skill level of the child. So a score of 1 indicates that the skill is not yet developed. A score of 2 to 4 indicates that the skill is emerging. and a score of 5 indicates that the skill is achieved. So scores will be recorded on this graph sheet, which will be provided at the end of the inventory. And the scores assist the clinician in identifying the child's current skill level as it relates to the domain of school readiness. So the K-Ready is intended to be used with children ages 3 years, 10 months to 5 years, 11 months that are diagnosed with autism who are currently enrolled in a 12-month special education preschool. So the inventory is a multimodal assessment that the OT can use to collect information from observation, interview, and previous evaluations. So I just want to provide everyone an example of what one of the subscales looks like. So this is the toileting subscale. As you can see, it is scored on a Likert scale of 1 to 5. So a child would receive a score of 1 if they do not indicate need for bathroom, a score of 2 if they inconsistently indicate need for bathroom or when they're soiled, a score of 3 if they inconsistently indicate need for bathroom before soiled or has 3 or more accidents per week at school, a score of 4 if they consistently indicate need for bathroom during the day, so they may have an occasional accident at school, and a score of 5 if they consistently indicate need for bathroom without any accidents at school. So regardless of how this child scores, they're still going to kindergarten. So as you can see, under the overall school ADL scale, this child has emerging skills in the area, and they might just need more support when performing those skills in the school setting. So I'm going to spend the rest of my time discussing my Capstone project, which was to assess the content validity and the clinical utility of the K-Ready. So content validity determines the relevance of the instrument items through a panel of content experts, and clinical utility assesses the usefulness of the tool in daily clinical practice. So again, developing an inventory for preschoolers with autism may assist in bridging that gap between the standardized and the descriptive assessments to evaluate school readiness. So this tool is to be used as an inventory to assess the current levels of some of just the basic skills needed for kindergarten, and it does not aim to be a comprehensive assessment of all the skills needed for kindergarten participation. So my study consisted of 2 phases. The first phase was content validity testing, review, and revision of the tool. And the second phase was the analysis of the clinical utility of the K-Ready. So phase 1 assessed the preliminary content validity of the K-Ready through a panel of 7 experts, and phase 2 assessed the clinical utility through a descriptive survey. So the study was approved by the Institutional Review Board of Columbia, and all the participants provided written consent prior to the start of the research project. And the aims of my study were to first assess the subscales and items of the rating scales of the K-Ready to see if they represented relevant, valid items for inclusion in the kindergarten readiness inventory as determined by a panel of experts. And the second was to see if the K-Ready can be practically used in daily clinical practice and if it covers items that reflect real life school tasks. So Dr. Graho and I invited 7 participants from a purposive sampling of OTs with expertise in pediatric practice and autism to review the K-Ready. The content experts had a wide range of practice experience with an average experience of 23 years in practice. All of the content experts had obtained a doctorate, and all of the experts had publications related to pediatric practice with a range of 1 to 74 articles and chapters. And all of them had 10 or more presentations on pediatric practice. And a total of 16 pediatric OTs participated in the clinical utility study. And these participants also had a wide range of experience from 1 to 35 years. The majority of them practiced in the school setting, and they were located in Iowa, Pennsylvania, New York, Tennessee, Missouri, Florida, Washington, and there was 1 participant from England. So the expert reviewers utilized a 4-point ordinal scale to assess the relevance for each skill item as 1 not relevant, 2 minimally relevant, 3 moderately relevant, or 4 highly relevant to determine item level and scale level content validity. So following the review of each subscale and the rating scale, in the K-Ready, an open-ended question to provide feedback or comments regarding the way that the test item could be improved was provided. So in order to assess the clinical utility, the researchers utilized a 5-question descriptive survey for participants to complete regarding the use of the K-Ready in clinical practice. So I just want to briefly go over the methods. As a reminder, the content validity determines the relevance of the instrument item through a panel of content experts. So in order to assess the content validity of the K-Ready, Dr. Graho and I calculated the item level content validity index, or the ICVI, which determines the relevancy of each item on the inventory, and the scale level content validity index, or the SCVI, which determines the total number of content valid items. So content valid items are items that were rated a 3 or 4 by the content experts on the Likert scale. So if the ICVI was greater than or equal to 0.8, then the item was rated excellent. The item that scored 0.7 indicated a need for revision, and the item that scored lower than a 0.5 were eliminated. So because we recruited a certain number of content experts with a varied degree of expertise and experience on the topic, there was a greater probability that the level of agreement may be due to chance agreement. So in that case, it was recommended by Polite, Beck, and Owen, 2007, to calculate the probability of chance statistic and the modified kappa statistic. So we then calculated the probability of chance to assess the level of agreement of chance beyond multiple raters. So after we got the probability of chance statistic, we calculated the modified kappa statistic in order to adjust for chance agreement. So items with a modified kappa of above 0.74 were rated excellent, 0.6 to 0.73 were rated good, and 0.4 to 0.59 were fair. So clinical utility assesses the usefulness of the tool in daily clinical practice. So responses from an open-ended question from the clinical utility study were analyzed using a collective case study approach. The responses were thematized collectively for commonly occurring themes, and the final set of themes were then sent back to all the participants for member checking to ensure the veracity of the data. And then once the participants confirmed that the themes reflected their individual and collective responses, we then finalized the data. So I'd like to spend a little bit of time going over the results of my study. So the content experts indicated that 15 of the original 19 K-Ready items were essential items and utilizes a rating scale that can assess kindergarten readiness in children with autism, as indicated by an ICVI of 0.8 or higher. There was one item, donned-off clothing, which is highlighted in yellow, required significant revision or clarification. There were 2 test items, cleans up and eye contact, which are highlighted in red, were indicated as not essential items in the tool. And the modified kappa statistics similarly reflected the results of the ICVI analysis with consideration and minimization of probability of chance agreement. So overall, the content validity at the scale level indicates that all the scale items are essential in the assessment tool, and the open-ended questions with opportunity for comments provided helpful insights in clarifying the language of the scale or modifying the criteria for items of the scale. So based on reviewer feedback, the cleaned up subscale was removed as the original item combined cleaned up of toys and clean up after meals. And as one of the content experts pointed out, those were 2 very different sensory experiences for children with autism. And that particular subscale was unclear as to the objective of the task. So additionally, content experts gave feedback on how it may be hard to quantify the amount of prompting or assistance during cleanup as a basis for school readiness. So the other item that was removed was the eye contact subscale. So one content expert indicated that based on clinical experience, adults with autism have frequently expressed an increased anxiety and physiological arousal surrounding eye contact, and that the lack of eye contact does not necessarily indicate an inability to learn, acquire skills, or an interest in the task. So additionally, several content experts asserted that OTs can better focus on addressing participation in meaningful school-related tasks rather than forcing kids to establish eye contact. The Dawn-Doff clothing subscale was significantly revised in order to provide clarification. So jackets, pants, shirts, and shoes were all included in the original scale, and the revised version now only includes jacket and shoes as the primary clothing garments that most children need to learn to don and doff at school. Sensory processing difficulties that are typical in many children were also mentioned as a barrier to effective dressing participation. So despite overall agreement that the scale items were essential, we decided to remove cleans up and eye contact, and we modified most of the other scale items for clarity and to improve scoring objectivity. So clinician reviewers who completed the clinical utility review found that the K-Ready is a potentially useful tool in practice, and there are 5 questions that we asked. The first was, does the K-Ready give an overview of items that need to be screened for kindergarten readiness? If not, what other essential items can be included? 2, do you think that the K-Ready is a tool that can be easily used in daily clinical practice? What are the opportunities and challenges in using the K-Ready in your practice? 3, describe the amount of time it might take you to complete the K-Ready. Is that something that can be included in your clinical assessment practices? 4, describe the format and language used in the K-Ready. Is it easy to use? Is it easy to understand? And 5, do the items in the K-Ready reflect real-life tasks necessary for assessing a child's readiness for kindergarten? So 4 themes emerged from the analysis of responses. The K-Ready is 1, a thorough assessment of school readiness skills. 2, it's generally easy to use. 3, may have potential challenges in administration in different settings. And 4, it assesses real-life school occupation as a reflection of ecological validity. So now that we have established preliminary psychometric properties of the K-Ready, future research will need to be conducted in order to establish the preliminary construct validity and test reliability of the tool using RASH methods, which will be led by Dr. Graho, and I will spearhead administering the K-Ready to 50 children. So future research is also needed to continue expanding the practice guidelines for school readiness and kindergarten transition, specifically for children with moderate to severe autism. So I just want to give a special thank you to Dr. Graho, who has been a wonderful mentor and an even bigger supporter. Could not have done it without you. Also, thank you to Dr. Serafian for reviewing my capstone materials. Thank you to everyone who made this project possible, and thank you to everyone who logged in to view this presentation. So now open up the floor to questions.
Thank you, Danielle, and congratulations for all the hard work. Dr. Serafian and I will lead the discussion. Again, if you have questions and feedback for Danielle, please feel free to type them in the chat box. Let me just switch to speaker view here. Danielle, here's my first and the biggest bulk of my question, actually. So 16 of the 19 items in the validation version of the K-Ready did in fact have good item level content validity index, and that was supported by the modified kappa index. But despite that, we actually modified every single one of them, even the 16 items that the content level experts said were essential. Essentially, all of the content experts as well really gave us really great feedback on how to modify each of these test items. And we were fortunate actually to have really great experts give us very specific feedback. So I'd like you to, and because you don't have time, I'd like you to take us through some of the specific qualitative feedback from the content experts on the test items. Can you give us an example of some of the modifications and revisions that we did as a result of the content validity review, and describe us through the revision process?
So one of the biggest revisions was the follow direction subscale. And a lot of the content experts kind of all said the same thing, that like, this is extremely important, but it needs to kind of just be adjusted a little bit for clarity. So we had done pretty much like the amount of queuing that was needed, but even that needed to be modified a little bit. So the original version, said things like unable to follow 2 to 3 step directions. They are self-directed. They can follow 2-step directions with modeling and then follow 2 or more step directions without assistance. So that needed to be clarified. So now the updated version pretty much just has, they can follow 1-step verbal directions with visual tactile cueing. So we changed a lot of the actual item descriptions to identify the kind of cueing needed and the number of steps that they're able to follow. So that was one of the biggest ones that we changed. I mean, all of them were changed. And it was interesting because a lot of the content experts kind of said the same thing. Like, yes, this is a very important tool, or subscale, but it just needs to be tweaked, in this way. The other one that I did want to mention was the transition subscale. So that also included the clarifying of the amount of support that was needed and the amount of cues that needed. And sometimes some of the items got, they overlapped a little and it was a little confusing. So with the original one that we had sent out to the content experts, we had included things like demonstrates difficulty with activity transition. So that included like tantruming, meltdowns, laying on the ground, handheld assistance, 3 or more verbal cues for activity transitions. And then with the revised version, now it does things like requires 4 or more verbal or visual cues for transition from preferred activity. So we really pared down with the number of cues, the type of cue, and that they're transitioning from a preferred activity to maybe a non-preferred activity.
Thank you. One more question before I turn it over to Dr. Sarafian. Can you also clarify for us how we use this tool? You mentioned this is a multimodal tool in terms of its objective. What do you mean by that? And talk us through on how does an OT use this tool?
So the tool can be, it should take about 15 minutes to administer. If that, and it could also be done through observation, talking to the teacher and the classroom staff, the other therapists that the child may be seeing, like speech or PT. And it's meant to just be an overall quick view of the child. So, you're going through and you can see where their skills are maybe not developed yet, or where they're still working on the skills. So, they may not be at an age appropriate level, but those skills are still emerging. They're still working on them. And I kind of see this tool as, going into these meetings as the kids are getting ready to go to kindergarten. It's like, okay, here is a very brief overview of the child. Where is the most appropriate setting for them? So kind of, gathering observations and maybe taking pieces from the standardized assessments and putting them kind of together in this one assessment.
Thank you. Dr. Sarafian?
Thank you, Dr. Graho. Great job, Danielle. Congratulations. And Dr. Graho actually addressed the 2 areas that I was interested in talking with you further, and that was administration as well as the content validation process. So regarding the content validation process, I imagine your experts gave you extensive feedback, qualitative feedback, sharing their experiences, because I imagine they all have a great passion for this population. Based on your experience being a newer therapist, were you surprised by any information, or can you highlight any information that you gathered from experienced therapists regarding the survey that surprised you, or you didn't expect, or it confirmed your hypothesis? How did that experience with expertise in our field really help you with this experience or change it?
It was really interesting. I was actually pretty nervous because I've only been an OT for 2 years now. So trying to, launch this project, I was like, is anyone going to take me seriously? Like, what kind of feedback am I going to get? Like, what kind of experience am I bringing to the table? So it was really interesting to get all the feedback. And I have one of the content experts, I have 2 of her textbooks sitting on my bookshelf, and I didn't realize it at the time until Dr. Graho was like, oh, do you recognize that name? I was like, oh my gosh, what? So that was pretty cool. But one of the biggest things, and I briefly mentioned it in my presentation, was the eye contact, because that, seems to be kind of like a big debate. Are we going to make these kids look at us in the eye? or are they still like listening and, you know, processing all that information, then they can still do the task. So pretty much all of the content experts were like, you know, this isn't necessarily an important aspect to address school readiness, because just because, like I mentioned in the presentation, just because a child isn't looking you in the eye doesn't mean that they're not interested, that they're not learning anything, or they're not attending to the task. So it was interesting for me as a newer therapist, because it's like, oh, well, the kid's not looking, like they need to look at me. And it's like, that's not necessarily the case in order to like complete a task.
Great. So it sounds like, you know, the experience of our assumptions as early therapists, or even throughout our practice, can sometimes guide our decision making. So assumptions that are made in developing a tool or doing our evaluation can sometimes do that. So it sounds like the qualitative information really helped you with refining this. Based on how you've now that you've completed this, is there an area that you would have included, or is there an additional topic that's related to a preschooler being ready for kindergarten who's been diagnosed with autism that you would like to add or further explore to enhance this tool?
I think I would add donning and doffing pants to the clothing, just because that's an important aspect in toileting. And then also grass. So instead of like going through the actual grass development, I'd rather kind of just include, like, do they have a functional grasp? You know, can they hold a pencil? Can they make a mark on a paper? So I would include that as well. I wanted to stay clear of adding anything sensory, because there are already so many sensory assessments in the tools, or available tools. So I think I would probably just add the pants, and maybe some more of the behavior, like maybe like a tantruming or like a rigidity subsection, because, you know, as I see with a lot of kids, if we're working on the alphabet, like writing the letters, if it's not in alphabetical order, there's a meltdown. So I would want to add a subscale on the rigidity during preferred tasks.
Okay, great. One more question. This is a survey. What standardized assessments through your educational process, what standardized assessments would you recommend to an occupational therapist who is evaluating a preschool or transitioning to kindergarten? What standardized assessments would be in our toolbox to help with this full evaluation process?
Well, like we use the Peabody for fine motor skills, you know, grasp, visual motor. The HELP is really good too. That we use, you know, the SPM. So kind of, I don't have experience, but I did a lot of research with the Mullen Scales of Early Learning, which seems to be a really good assessment as well. I just don't personally have access to it. But, you know, taking all the available assessments and, you know, bits and pieces of them to kind of build this tool was helpful.
Great. Thank you.
I have an additional question for you, Danielle. We focus a lot on the content validity. Let's go now to the clinical utility part of the study. You have 16 participants, correct? Mostly from the United States, a variety of clinical experiences. And the final table in your digitation showed some of the themes and some of the example verbatim quotes from the qualitative study. In summary, the participants, though small in number, talked about really they want to use the tool and it's potentially useful. But a lot of them also mentioned a lot of challenges in potentially administering it. So go through in a little bit more detail in terms of the feedback from the clinical utility study, and do a sort of risk ratio analysis of comparing the challenges they posed and the potential utility that they've also given feedback on. Do the challenges outweigh the potential usefulness of the tool? And if so, what should we do, or what do you need to do to revise the tool to enhance clinical usefulness?
So I think the biggest thing that people said, because when we had proposed it originally, it was, you know, this could take 45 minutes to administer. But a lot of the feedback that we got was like, I don't think it will really take 45 minutes. And if it does, then that may be over a couple OT sessions. So I think in, you know, as we go forward and administering it in clinical practice, kind of seeing that, oh, maybe it only takes like 15 to 20 minutes. because a lot of the things will be just done through observation, and a lot of the scale items are things that kind of already happened during a typical OT session. So I don't think that the risks really outweigh the benefit at this particular moment. But I think that addressing the amount of time that it takes as I administer more of them will be adjusted.
Also, comment a little bit more on, right now we're all using telehealth, and you're using telehealth, and we've had this conversation about how challenging it can be, particularly for children in the autism spectrum, to sit them down or have the parents facilitate therapy sessions. Do you think that someone, a therapist, during these times will be able to use the K-Ready using a telehealth platform?
Yeah, I think you can do a lot of the item, observe a lot of the items. You can even talk to the parent, toileting, dressing, part of the morning routine. How are those things going? But you can also do some of the fine motor and the visual motor over telehealth. So it's like, okay, let's draw this picture together. Let's draw this figure. And kind of also see the frustration tolerance, which is one of the subscales, on the level of the child as well as the level of the parent, and kind of see if that influences each other. But I think that this is a tool that can be used over telehealth based on observation and a lot of the parent input. So yes, it's particularly based in the school setting, but I think right now, because school is at home, it can still be used.
I also want to echo quickly one of the comments of Dr. Sarafian from reviewing your capstone artifacts, and I think it will be helpful to discuss that here as well. We noticed when you presented the tool that you didn't give us information about scoring. Is there a domain score or a subdomain score, or how do we interpret the scores?
So we haven't done score interpretation yet, and that is on purpose. So we still need to do further analysis to determine the sensitivity of the rating scale using RASH methods, which will be next step.
Okay, and actually that's a good question from Dr. Gillen on the chat. What are your next steps? Any specific details on that?
Yeah, so Danielle, congratulations.
Thank you.
Great presentation. But I'm reading the comments and I'm hearing from your qualitative data, everyone's very excited to start using this. Is it ready for use, or does it need more work before it's adopted in clinical practice? Is continuity enough to say this is a tool that we should be using?
I think it needs a little more work just because we haven't established the construct validity or the test reliability yet. We just have the very basic psychometric properties. So I think, as we do more studies, then it'll be more readily available for widespread use.
So do you see yourself doing that now that you're graduating and going forward and completing the psychometrics of this tool so that it could be used in clinical practice? Because it sounds like you're saying it's too early to use.
Yeah, I definitely want to keep doing studies because I've, poured my heart and soul into this assessment.
Sounds
so for it to just kind of stop, I don't want to do that. So we'll keep doing the studies.
Well, congratulations. Thank you so much.
We're already beginning to draft the IRB for the next steps, actually, because she really indicated to me, I really want to keep the momentum going and continue working on it because of the feedback we've received, right?
That's great. Yeah. Good job. Good job.
Thank you. There's a quick question from Dr. Kaplan. Do you see and how do you see this assessment influencing the direction of OT treatment for this population?
I think that it will help develop a more uniform language across the spectrum because even, I've talked to some of my other, school friends that are in preschool settings, and everyone kind of, everyone talks about the same thing, but kind of uses language a little differently. So I think that a tool like this will kind of help everyone kind of remain on the same page and make it be uniform across preschool settings.
All right. Thank you. Congratulations, Danielle. You're done.
Thank you.
Well, for now, We're gonna take another quick 5-minute break, and then, and again, there's a lot of questions and feedback as well on the chat box, Danielle, so feel free to go over them. Again, thank you, Dr. Sarafian, for all of the great feedback you've given Danielle and us in this project, not just towards the end, but even through the phases. We're gonna take a quick 5-minute break, and then we'll transition to our last presenter, Stephanie Hoy.
Dr. Alonzi Gold, Doctor. I just love saying that.
Probably like, I need to breathe. I need to breathe.
I'm sure it's very stressful, but everyone's been so eloquent so far. It's great, and I know Stephanie will be just as eloquent going forward. So, hi, Mari. I didn't see you before.
Hi, Glenn. Was that me you were just saying hi to?
Yes, I didn't see you earlier, so I just...
Yeah. I got on about 2 minutes late, but that's it.
Oh, there's a lot of people on, though, so I'm trying to scroll through, but a lot of people are on no videos, so that's okay.
Yeah, if you're here, let's give you a quick couple of minutes. Turn on your videos. We just want to see everyone who's on the call today. We still have 47 people.
Hi, Lev. Lev, how are you feeling? Are you okay? You're muted, Lev. You're muted. You got to unmute. You're still muted, Lev. Just give me a thumbs up. Are you doing okay? All right, good. 2 thumbs up. Oh, wow, even better.
My mother is from Indonesia.
You're in Indonesia?
My mother is watching from Indonesia right now.
Oh, wow.
Oh, yay.
That's amazing.
Oh, so sweet. This is so sweet.
And I know
hello, Mom from Indonesia.
Hello.
Hi, Mom.
And I know a lot of people from Kennedy Center are here right now. Give us a wave as well, please, if you're here.
Hi, Amanda. Hi, Danielle. Hi, I feel like it's, what was that show when they said your name at the end? Like, hello, Glenn. Hello, Lennon. Like Rom or something. And
Rim.
they never said Glenn, though.
Never said Laurel either.
Yeah. It's like when you buy a license plate, like with your name on it, there's no Glenn. 2 N's if there's anything. Janet, are you in Florida? You look like you're in a sunny place, actually. Janet?
Me?
Yeah, you look like you're in a sunny place.
No, I'm sitting, I've got a window open where it's raining outside, and I have another window that you can't see, but it is overcast and crappy. Just as, but
hello,
when you live in suburbia, you know, without huge buildings blocking whatever light there is.
Right.
Did Danielle, is Danielle coming back?
I think she's just muted, actually.
Oh, is she just only muted?
Right here.
Hi, Danielle. I just wanted to congratulate you and say hi to Mom.
I think Mom is on the call. Mom was on the call.
Mom's on. I saw is Vincent.
Send her my best. I haven't seen her for 2 years now.
Danielle, is
her
Vincent
mom inside my office more often than any mom we've had, except for Phyllis's mom, who lived in my office.
Danielle, is Vincent your father?
Yeah.
Yeah, okay, she was on. I saw her. I saw
well, congratulations to you.
Thank you.
Hello, Paul Arthur. How are you? You look very comfortable on your couch.
I'm well. I'm at the lake, but it has a really low bandwidth, so I'll just be on for a little bit.
What lake are you on?
Amanda Rudnick.
Yeah, I'm in the Midwest, kind of right between Ohio and Indiana this week. So it's called Reservoir. You can kind of see a picture behind me.
Did you have tornadoes yesterday, or was that a little further south?
I believe it was further south. We did have them in Florida, but I skipped out. So.
Yeah, scary times with the weather, my God.
It is so cool seeing former students. I love this.
I know. I just
I'm
saw
looking at
Allison,
my
and there's Stephanie. We're here to see her today.
And there's Amanda and Sadie.
I know.
Giselle.
Sadie Lucina. Oh my God. Look, and
Van
Michaela.
Lemon has a beautiful
Michaela has
kitchen,
a new
actually.
hairdo.
Allison with a baby.
Yeah. Allison with a baby.
On the floor too.
The last time I saw you, Allison, was Bed Bath & Beyond, and I was like a wreck.
Our lives have changed since then.
And Michaela has a great haircut, I see.
I see.
It's seen better days, you know.
We all it's called Corona hair.
But there are also people from, I think, before your day. I see Lynn, I saw Joan.
I saw Lynn Grasso, I see Anna.
Lynn Grasso looks exactly the same. How is that possible?
And Lynn Grasso is
joining. Be blanked out in the next one of these.
Really? Lynn, you're joining the program?
Yeah, she's been a
Yes.
in the
Yes. Thank you for your help. Phyllis Simon, I sent her a message. Talking with her last year at the event was what convinced me, the final thing that convinced me.
Good.
Oh, nice.
JFK did, yes.
And I see Dr. Mahoney's on the line too.
Yes,
Dr. Mahoney.
Mari.
How's your baby?
Yesterday, this was me.
Yeah.
How's the baby?
Dr. O'Neill.
Sleeping.
Good.
If I go in and out, it's because I'm going to check on him and then I'm coming back.
So he's like 13 months now, maybe? Or
Yeah, exactly. He's 13
Yeah.
months.
I
When I
thought
gave
so.
my presentation, he was 6 weeks old.
Oh, God.
Lennon and I look at his pictures when he gets a new one of Maverick.
I remember finding your mother in the lactation room. I was like, Mom, it's time to come in.
So funny. And still breastfeeding. 13 months strong.
TMI.
All right, everyone, we're going to transition now.
No, this is fun, Lennon. Can't we keep chatting? Okay, I'm only kidding you. I'm muting myself.
So I'll ask everyone to put themselves on mute again. We're going to transition now to our last presenter. Our last presenter for today is Stephanie Hoy. She will be introduced by her mentor, Dr. Katherine Dimitripoulou, and her capstone reader is Dr. Rochelle Mendonça. Dr. D.
Hi, everyone. Such a great day so far. So it is my pleasure to introduce Stephanie Hoy. Stephanie is a seasoned clinician dedicated to improving the function and participation among children with severe and multiple disabilities. She is a CEOT alumna, so we're very, very proud of her for this next stage of her life and her career. She has completed her residency throughout this doctoral work with 2 institutes, iHope and iBrain, where she was able to interact and get feedback from parents and children with severe and multiple disabilities. Her work in this doctoral program has been very thorough, systematic, and I think innovative. Her dedication to develop the I Can Play assessment and guideline for practice, I think contributes significantly to clinicians' understanding of how OT and assistive technology can interplay and improve the lives and participation of children in this population. Children and practitioners who gave feedback, as well as educators who gave feedback throughout the process, attested to how hardworking she is and how dedicated she has been to see these projects to come into clinical practice up to now and also in her career in the future. I would like to introduce her and invite her to present this project. And I just wanted to say that it has been a pleasure and a real mind-provoking experience to work with Stephanie, and I look forward to her successes with this work.
Thank you so much, Dr. D. I'm going to share my screen. Okay, so hi, my name is Stephanie, and thank you so much for coming to my capstone presentation. Just a little bit about myself. I've been an OT for a little over 6 years, and I was recently working at an inpatient rehabilitation unit at the Children's Specialized Hospital. As Dr. Dimitripoulou mentioned, I completed my clinical residency at the International Academy of Hope and the International Institute for the Brain, 2 specialized schools for children with brain-based disorders and severe multiple disabilities. I quickly became very passionate about the population of severe multiple disabilities, and I wanted to be an agent of change through facilitating their interactions with their environment and with their families through their main occupation of play. My capstone presentation is about the development of the interactive child activity narrative of play, also known as the I Can Play, a framework of assessment and intervention of play for children with multiple disabilities. For the purposes of my capstone project, children with severe multiple disabilities will be referred to as SMD and can be defined as children with chronic medical conditions, use of medical devices, including but not limited to tracheostomy tube, feeding tubes, wheelchair, and that have significant physical limitations that can be combined with language deficits. So what is play? Play in its truest form is self-initiated. Play is the ability to suspend reality, explore the environment, and more importantly, play is fun. The nature of play in children with SMD is different than typically developing children. Children with SMD are more likely to depend on their caregivers on the types of play, activities of play presented to them, resulting in play becoming very passive and a lot of hand-over-hand assistance. Thus, play doesn't become self-chosen or self-initiated. However, with the use of assistive technology, children with SMD can engage in more independent play and explore a wide range of activities. During my first semester, Dr. Dimitropoulou and I conducted a scoping review on play with children with cerebral palsy. We found themes of caregivers reporting that my child only plays through watching others, my child only plays in therapy, play becomes a burden on my family. These comments really resonated with me and served as a guide for creating the I Can Play. The I Can Play framework was created to empower children with SMD and their families to create client-centered and meaningful goals, to assist therapists to facilitate play in various social and environmental contexts. The I Can Play assessment is compatible with assistive technology means, so children with SMD can be an active participant. My capstone project focuses on the development of the practice guideline, development of the assessment tool, and conducting the content validity and clinical utility study. However, before talking about my capstone, I would like to show you some of the artifacts I completed prior to the capstone. My first artifact is the case study conducted in the Neuroscience of Cognition course, where I was able to analyze the neural underpinning of a child with shaken baby syndrome. This case study allowed me to further understand the neurophysiology that occurs in children with SMD. At the same time, during the Advanced Theory course, I created the first version of the I Can Play practice guideline for assessment, which honed in on the occupational theories of the ecology of human performance and the cognitive theory of the dynamic interaction model. These theories helped me create the first version of the essential elements, which were a client-centered approach to evaluation of play, a holistic exploration of meaningful play activities, active involvement, assistive technology approach to evaluation of play, analysis of person-context match to optimize play, caregiver capacity, and assessment in natural environments. We will see how this practice guideline transforms in future slides. From an educational perspective, I became very, very passionate about the use of assistive technology to facilitate participation in children with SMD. So I decided to obtain an advanced certification as an assistive technology professional, which has helped me grow in my expertise and my career opportunities. It has given me the opportunity to conduct presentations and trainings. I was able to present at the Closing the Gap conference along with my colleagues at iHope. I was able to present a short course with my mentor, Dr. Dimitropoulou, at AOTA 2019, multiple interdisciplinary in-services at the International Institute for the Brain, and we had an accepted poster presentation at AOTA 2020. As the I Can Play project grew, we quickly realized that we needed further funding to conduct more studies. In August 2019, I was awarded a grant from the Salmon Center for Innovation and Research in Occupation-Based Technology that supported the equipment and the procedures to conduct content validity and clinical utility studies. With the expertise in my measurement course, with the expertise and guidance of Dr. Graho, I created the initial version of the I Can Play assessment. The initial version of the assessment included 29 items that were decided based on observation and research. We will dive further into the assessment tool during my capstone presentation. From the original theoretical guideline mentioned in the earlier slides, changes were made to theories to really start at the child's ability and to focus on the child's self-determination and self-efficacy to choose activities. So we changed some of the theories to include the human activity assistive technology model, Takata's stages of play development, self-determination and self-efficacy theory, and Vygotsky's theory of learning and development to support the assumptions of the child's self-efficacy, the use of assistive technology, and the creation of a supportive environment that can facilitate play and learning. Additionally, we made changes to the principles of assessment of the essential elements, and we included new principles of intervention, which include partner-assisted play, so how a caregiver, parents, teacher can facilitate play, the I Can portion, which is the assistive technology assistance for play, getting rid of physical barriers and how the child can participate, to the development and learning through play, increasing playfulness and engagement with tasks through modeling, and the context of treatment. So here's an example of a child's result. So the child will identify their wants, their frequency play, and their context of play. For example, this child in particular said that he likes cars, dolls, and balls. He wants to play with cars, dolls, and balls. And he does it mostly through electronic means. He says he doesn't play cars often, but he wants to do it more. He plays with dolls often, and he continues to want more. He plays with balls often, but he does not want to play with balls anymore. The context of play, as you can see here, he mostly interacts with adults. So from the assessment result, it compiles a play profile that can help caregivers and therapists create intervention strategies. So some of the intervention strategies would include adding more independent electronic play during free time schedule, increasing peer interaction, working with therapists and parents to incorporate his preferred activities, and encourage more free play at home. In February 2020, the practice guideline was accepted for publication at the Open Journal of Occupational Therapy. Dr. Dimitripoulou and I chose the Open Journal of Occupational Therapy because of its interest in technology-based research and the journal's open access feature to reach a wide range of professionals. Oh, sorry. Sorry, Zoom is acting funny. Sorry about that. I don't know what happened. Technical difficulties. Thank you so much for your patience. From the culmination of all the classes for my Capstone project, we conducted a content validity and clinical utility study that was granted approval by Columbia's IRB board. The I Can Play assessment was developed for school-age children that have severe multiple disabilities, and it is an ipsative, non-standardized criterion reference assessment. This non-standardized nature of the assessment is intentional to meet the individualized needs of children with SMD. The I Can Play assessment is one of a kind in terms of its compatibility with assistive technology methods of eye gaze, switch scanning, and touch selection. The child is able to have control over their own pacing of the assessment. All questions are pre-recorded to ensure consistency. Another unique aspect of the assessment is that it evaluates the same concept of an activity in its physical format and electronic format. By doing that, we can see if barriers to engagement are due to physical abilities or cognitive abilities. The I Can Play assessment provides information about the child's play preferences, play desires, play frequency, and social and environmental context of play. The goal of the assessment is to help therapists, teachers, and caregivers identify meaningful activities and goals for the child to expand their play repertoire. So here's a brief overview about the administration of the I Can Play. First, the therapist and caregivers will determine the child's access method. Once established, the web-based version of the assessment will be downloaded onto the device. The child will be asked a series of 18 questions of physical play items and 16 questions of electronic play items. The items are divided based on Takata's taxonomy of play depicted here. Physical play is defined as tangible items that the child can interact with, and electronic play are games on the computer or iPad. At the completion of the assessment, the child and caregiver can also identify 3 preferred activities not listed on the assessment. Here's an example of how the assessment would go. So the first step is I would present the object to the child. The child would have 1 or 2 minutes to interact with it. And then I would launch the web-based version of the assessment, asking the child, do you like this activity? Yes or no. Once the child answers, it will launch the next session, which is, do you do this activity often? Yes or no. And do you want to do this more? Yes or no. A child must answer 2 out of 3 yeses in the preference section in order to be asked the context questions. So the context questions are, who do you play with? Myself, friends, parents, and teachers. Where do you play? School, home, or the community? The procedure was conducted in 2 phases. The first phase was the recruitment of 2 children participants to complete the assessment in its entirety. The inclusion criteria of the participants were ages 7 to 18 years old, a diagnosis of multiple disabilities or brain injury on their IEP, had 2 or more muscular or sensory impairments, medically stable, cognitively able to answer yes, no questions consistently, intact hearing, have been using or exposed to assistive technology for a minimum of 3 months. Here are the demographics of the children participants. So one child was 14 years old, female. She is a dependent wheelchair user, emerging power mobility user, and according to the gross motor function classification system, she's on level 5. Her communication methods, she uses switch scanning and Tobii eye gaze. The second child was an 8-year-old female. She's a pretty proficient power mobility user. She's able to scoot inside her house and ambulate with close supervision. Her GMFCS was a level 4. She uses gestures and touch selection on her communication device. The second phase of the study included recruiting a panel of experts consisting of 7 occupational therapists for the content validity and clinical utility portion of the study. The inclusion criteria of their experts were having worked with children with SMD for a minimum of 3 years and a minimum of 1 year of using assistive technology with the population. The panel of experts had varying levels of experiences with a mean of 12 years. The geographical breakdown of the experts included 5 in New York State, 1 in California, and 1 in New Jersey. The experts analyzed the videotapes of the children performing the I Can Play tool and rated each play activity and domains based on relevance, necessity, and clarity. The clinical utility was measured through a Likert scale of 1, not needed in the field, hard to utilize, to 5, highly useful tool, fairly easy to utilize. The quantitative and qualitative data were analyzed using a mixed method approach of descriptive statistics to obtain the mean and median scores. A sentence-by-sentence structure analysis was used to extract themes for the qualitative data. The results from the I Can Play study were pretty positive. On the area of relevance, the I Can Play's median score was a 4, which was highly relevant on 33 out of 36 items, with the exception of 3 items that received the second highest score of a 3, which was quite relevant in the area of flipping pages through books, pre-construction phase, and point-based games. In the area of clarity, for physical play, The experts reported that 2 items out of 34 were quite clear, so having the second highest, which included creating and point-based games, and 1 item, which was dancing, received a somewhat clear. In the area of electronic play, 12 items received the highest score of very clear, and 4 items received the score of quite clear, and those included pre-construction games, building games, creating, and dancing. So there's some overlap between the 2. The I can play necessity median score was 1 meaning that it was necessary for a majority of the items. In both physical and electronic play, some experts have rated the activity of dancing and swimming to be 2, useful but not necessary. In the clinical utility findings, 1 expert reported the assessment to be highly useful, easy to utilize. 4 experts reported the tool being useful and can be utilized, and 2 experts reported that the tool is useful and hard to utilize. From the qualitative data, we extracted themes of the item being a useful tool, functional, a variety of activities to explore for the population, would benefit from adding a caregiver assessment scale, but the tool is also lengthy. The experts reported their biggest concerns was the length of time to administer. Although this was also a concern we had from the beginning, we wanted to ensure that the assessment was comprehensive and encapsulated all 5 play domains. The length of time was also highly dependent on the child's endurance, processing time, wait time, and medical stability. For example, child X required frequent rest breaks, feeding, and secretion management, and child Y required frequent cues for redirection. However, it is really important to remember that this is also the nature of kids with severe multiple disabilities. We also considered adding a caregiver assessment scale. However, at the time, just for the purpose of this capstone, we wanted to focus on a evaluation tool that the child could participate in. Based on the feedback, modifications will be made to the I Can Play assessment. The revisions will address increasing clarity of the administration directions, reconsidering some of the relevance items to help decrease length, and modifying the format to start close to the child's chronological age and going up and down, similar to like the Peabody scale. Additional information that I found from the 2 children participants were the validation from their parents on how the results truly depicted their interest. One of the participants fell right in her developmental age level of play, which was really nice to see. And one parent expressed that she saw an immediate difference between the interactions of the child and her 5-year-old brother, because the 5-year-old brother finally saw her play. Both parents indicated that through the play profile, they would like to seek out environmental and social modifications to facilitate play at home. In the future, we hope to continue this work by creating modifications, working with software engineers to create this as an app-based assessment that can be downloaded onto any device. From a research perspective, we would like to conduct test-retest reliability and inter-rater reliability studies, and also increasing the number of participants. Prior to starting this program, I really wanted to learn how to be a better advocate for children with SMD. I wanted to obtain a grant, create an accessible assessment that children with SMD can participate in, have more experience with presentations, increase my knowledge and evidence-based practice for this population, and conduct a full study. At the end of this degree, I was able to meet and exceed all of my goals. I would like to say thank you to everybody for attending the presentation, and I would like to say a great thank you to all the professors at Columbia, especially my mentor, Dr. Dimitri Poulo, who served as an inspiration throughout this degree and who played a very crucial role in the development of this project, and Dr. Graho for his passion and guidance throughout the degree, my husband for always supporting me, my friends and family for their love and ongoing support, and to all the children that really inspired me to pursue this degree. If you have any questions or would like to learn more about the I Can Play, here's my contact information. Thank you.
Thank you, Stephanie. All right, we'll give the floor to Dr. Dimitropoulou and to Dr. Mendonça. Again, if you have questions, feel free to type them, and any feedback for Stephanie in the chat box. Dr. Dimitropoulou.
Thank you, Stephanie. That was a great presentation and, of course, inspiring work that needs to be continued. Given the nuances of this assessment tool to try to give voice to and language and interaction to children that don't necessarily have that from verbal communication, can you give us a sense of how that tool was administered and how do you have any examples maybe to give us, to get us into the context of this evaluation and how it might feel?
Yeah, sure. So I'll give you an example about the web-based version of the assessment. So this is a platform that I use with the children. So the first activity was, do you like this activity? So I would present the object, so for example, Legos, and the child would interact with it. I would model building. And then they would answer a question. Yes. So let's say yes. Do you do this activity often? And then the child would answer, no. Want to do this more? Yeah, so those are some of the questions that are examples used in that assessment, but it's also important to remember that the I Can Play, it doesn't really give a score, it gives a profile. So the application will store all of these answers and generate that profile for you. So it's a really hands-on, easy tool to utilize for therapists.
Thank you. Thank you for that. Now, having this context or a little bit of this preview, can you share with us as a clinician who actually administered this test to two children, what was your experience and what were the things that were useful or good that worked and things that you found as being more, harder to tackle? A little bit on the clinical utility aspect of it.
I think my biggest reflection about conducting the study was videotaping children is very difficult, but I'm really glad I got to experience it, especially with children with SMD. Like, it really just opened my eyes to see, yes, maybe there isn't a tool, an active tool for this population to participate in, because it does take a long time. You require increased processing time. You have problems with arousal sometimes, and also just finding that common communication. I think Dr. Dimitropoulou and I did a lot of just studies and observation on looking at the physiological level of reaction of these children, like when they're fatigued. So those were like some of my concerns, but then also some of the highlights of it was the parents immediately saw such a big difference, and like the children, when they were exposed to some of the activities they haven't really seen before, their level of engagement, their level of arousal, and everything just kind of changed. And some of the parents afterwards even were giving me feedback and asking like, oh, like this girl is looking for you, or like, how do you get this game on the computer? So I think just expanding their repertoire would be like life-changing for them.
Yes, I completely agree. One quick last question, if it can be quick. The idea of why a guideline, why a theoretical framework to supplement something like this? What do you think is the usefulness of having a guideline behind the process of this assessment?
Yeah, I think one of the great things about the guideline, and the most important thing, is when we were going through presenting these at conferences, everybody was like, but where do I start? And that where do I start question really kind of like propelled me into making a clear guideline for assessment and evaluation to kind of facilitate flexible thinking for other therapists to work with this population. on like where to start, how to go from there. And like, although they don't have to strictly follow it, but at least it serves as a starting point. The theories also instill the notions of self-determination and self-efficacy, and reminding everybody that like, although these kids can't verbally communicate, they still deserve the right to advocate for themselves and give and tell people what they want to do.
Thank you, Stephanie. Dr. Mendoza, could we get your questions on the phone?
Sure. Stephanie, fantastic project. I had so much fun reading through artifacts. And you actually answered a lot of my questions that I had through the readings when you presented today, which was great. I have three specific questions, I think. So you developed the assessment, and then you're providing an intervention guideline, right? Yes. How detailed is your intervention guideline? What's the purpose? Are you really depending on clinical expertise to use the assessment results and just automatically, or not automatically, but develop intervention processes? Or do you provide examples for each scoring level of the assessment?
Yeah, so the intervention guideline, hopefully will be out in OJOT soon. Yes, it gives like it doesn't give like specific examples of what to do, but just like general guidelines. So for example, for partner assisted play, how can teachers and adults facilitate play instead of doing hand over hand assistance, like thinking about positioning, thinking about eliminating environmental distractions, ways to cue the child, or in the AT part of the intervention, I think that gives a lot of very specific guidelines of like different items that can be utilized with this population and just like different ideas on how to utilize it. So in a way, it's not too rigid, but it is rigid in some ways.
Yeah. Yeah, because I think for people who might not be very familiar with how to facilitate play, which you're right, it's not something we instinctively think about initially, but I think providing a few more examples, or examples of interventions that can be applied to different types of play is very useful. So that's great. Another question, as you did a very extensive review of current play assessments. There aren't a lot, but you actually did quite a comprehensive review of them. What do you feel was really lacking in current play assessments that you feel you addressed in I Can Play Now?
Yeah, I think all the play assessments out there are so wonderful. The Parham textbook like really helped me a lot. But like when I was going through the measurement class with Dr. Graho, I felt very passionate about, wait a minute, why can't the population I work with participate in any of this? And during like the IEP processes, all of the assessments were observation-based or like caregiver reports, and I really wanted to steer away from that. I wanted to give a voice to the children I work with, and I think that makes the assessment different, and also its compatibility with assistive technology methods, and analyzing a physical play versus electronic play, because I feel like we could do a whole different study on that. But I think like all the play assessments are out there. We use a lot of them as our guide.
Right. That's great. My last question for you. So your inclusion criteria for your study was kids aged 7 to 18, right? Do you feel like there is an age range that this assessment would actually work best with, or an age range it might not work with?
At first when I first developed it, I really wanted to be for like school age children. And then from the feedback from my experts and everything, because these children developmentally, they're kind of all over the place. So I think there is like potential for the age ranges to be expanded from like 5 to 21.
Right. I can see that happening actually, because I found your age, I actually think the way you've developed it, it can apply to a larger population than you used in your study.
Yeah, thank you.
Wonderful. That was my questions.
Stephanie, I have Dr. Dimitripoulou, any other questions?
No, I'm good. I wanted to others.
Sure. I have a quick comment and then a question for you, Steph. First, comment. I remember from the theory course when you were drafting your very first conceptualization of the theoretical guideline, it was very apparent, and really, one of the long conversations we've had about your essential elements is that the majority of comment is that for this population, play is always directed to them. It's the adult or the teacher playing to them or towards them, rather than the child really developing that agency, that self-initiation, and that level of choice of what you wanted to play. And it was really sort of, you know, an aha moment for us when you labeled this as "I can play," because it really signified that intent that it has to come from the child. Now, that said, some of the common comments from your clinical utility study is that the assessment tool is lengthy.
Mm-hmm.
And you know, this is a common conversation I have with many of the students taking the measurement course. The trade-off between how long an assessment tool is, and the specificity of the tool to be able to hopefully be sensitive enough to measure the construct. And this is very particular as well with the assessment tool that I developed. A lot of comments were that it's lengthy. And sometimes you have to create a trade-off between clinical utility and the specificity of the tool. In your future directions, as you revise the tool, what are your thoughts about addressing the length comments? How much or how little are you willing to trim or to adjust it for ease of use, but also to make sure that you're not trading off the specificity of the test?
Yeah. I think one of the ways that we were going to address the length comment is, starting at the child's close to their chronological and developmental age. So for child Y, for example, she was 14. So we would start at like recreation and leisure. Based on her results, we would either go backwards or down. I think for this population, and one of the reasons, and especially like we learned in your class as well, is like the beauty of non-standardized assessments and like the importance of it. And I think as a field, like a lot of people are very stuck on the standardized notion, but for this population, there is absolutely very little way to make it standardized, and it shouldn't be, because a lot of the standardized tools in that regard make the child score lower, or like it's very unfair and biased towards their performance. But I like, in terms of the items on the scale, maybe like one or two, like consistently dancing scored low in a variety of categories. So like maybe that's one to reconsider. But length, and I would do more, have it administered between 2 days instead of kind of reducing the domains.
Yeah, that was my question as well. Could you administer it, split the administration instead of one time into multiple sessions and build it in the therapy sessions?
Yes, yeah, especially with this population, you know, like you usually see them multiple times, a long time.
Mm-hmm. There's a question from Dr. Kaplan, Stephanie. She said this function-based assessment is so very needed for this population. Wonderful presentation. Your item responses are based on language comprehension of the questions. How are you making decisions about a child's comprehension level to adequately engage in this assessment?
Yeah, I think that's a great question. I think that's why the importance of like working with the team. So like if we see this child at school, like knowing what the speech therapist has to say and like where they're at. Also the parents and caregivers. And even if like they don't have a assistive technology device that they're using, gestural cues of them smiling, you know, if you're playing with an item and they smile or they're not interested, using those behavioral cues to kind of make this decision as well.
And I'll channel my Dr. Gillen here. You've talked to us about the revisions. What's next? What are your next steps?
My next steps is hopefully to secure more funding to work with the software engineer and really making this available. I think we got a lot of positive feedback after conference about people wanting to use it. So hopefully I can make that happen.
That's great. Dr. Gillen, do you have a comment or question?
I have a closing comment. Stephanie, great job. So proud of you, but not specific to Stephanie. Just when you're ready to call on me.
Sure. All right. Any other questions? I think that's it. Thank you, Stephanie, and congratulations.
Great job.
I'm going to do a quick closing statement as well, and then I'll transfer to Dr. Gillen. So before we wrap up, I just want to say first, officially, hopefully this loads up soon. Again, I just want to say officially, I'd like to congratulate our doctors, Dr. Katherine O'Neill, Dr. Phyllis Simon, Dr. Danielle, along with and Dr. Stephanie Hoy. So let's all give them a virtual warm round of applause. We hope to be able to host you and your special guests for a reception and an in-person celebration sometime in the future when the situation allows us to do so. But I also would like to thank the mentors, the capstone readers, our amazing OTD faculty, the faculty in the program, Dr. Gillen for all the support. Thank you to the families, the loved ones, all the pets who've joined us during classes, all the roommates, spouses, and partners. Many of them know me very much by my voice throughout the year-long courses. All the employers, patients, colleagues, and guests available and joined us today who have supported them all. A big congratulations to you as well. And to all our current, incoming and prospective students who joined us today, it will be your turn next. We're excited to and look forward to your own projects. And I'll turn it over to Dr. Gillen for some closing comments.
Congratulations to our new doctors. And again, I feel like Papa Bear today. Like I'm so proud and warm. But I also want to say this has been a really hard 6 weeks, 7 weeks for all of us. And I will actually say that this morning into the afternoon has really rekindled my spirit and made me proud of all of you. And I feel a new level of motivation that I felt was dropping during this quarantine situation. So you have done amazing work. You've done amazing contributions to the profession, OT and beyond. And thank you for warming our hearts, and congratulations, and use your doctor title to get reservations when we're allowed to go back to restaurants. Okay.
All right, so we will stay on the platform for a few more minutes for congratulations, feedback, conviviality, but thank you all for attending today. I hope you all keep safe and have a great weekend. Thank you so much for joining us today.
I will proudly say
thank you for inviting.
Have a very big drink for all of you tonight.
Amazing job. Congratulations.
Everybody did an amazing job.
Congratulations, everyone.
Congratulations.
Take care.
Yeah.
Stay safe.
Congratulations. This really was fantastic. And, you know, one of the things what Laurel had said, you know, I think 2 presentations ago,